Today, as you know, I'm Jill Slocum, I'm the chair, and I'd like today to start with welcoming new members. They're not new to the council, but they're new back on our committee. Councillor Graham Oakes, who missed it so much, he needed to come back, and I thank you for that, Graham. Councillor Val Keach, who's got a wealth of knowledge, and Councillor Alistair Hendry, who's not here, Councillor Ben Ferguson, not here, and Councillor Derek Perry, not here. So that's a good start. So they will be dealt with accordingly. I'd also like to tell you that my vice chairman, Edric Hobbs, has been appointed the vice chair, but was obviously he didn't realise he was going to be appointed, and he had a holiday already booked. So we'll forgive him, and he won't be any beatings. There are no planned fire drills today. In the event of a fire, please exit the building in the normal way, main reception, and let Democratic Services, they will know. And the assembly point is outside on the job centre, which is over there. The agenda pack is via ModGov, directly from the council's website, with a link which was sent out to all members. I'm requesting the normal way, please turn off phones, microphones, anything else that can disrupt the meeting, because that can be very, very noisy. When I invite somebody to speak, could you clearly state who you are for the benefit of anyone who's listening and to the meeting so they can identify who is speaking? Can I remind all committee members to keep the chat solely for business only conversations, and the agendas are now viewed electronically? Could I request that, I'm so sorry, it's even happened to me, look. As agendas are now viewed electronically, could I request that members and officers refer to page numbers so we know exactly what you're speaking about, okay? So thank you very much. Could I also welcome the people online? Especially officers and everyone are welcome to being there. I'm now going to invite Jack Latkovic, the governance specialist, to list any apologies and substitutes, please. Thank you.
Good morning, everyone, and thank you, Chair. We have received apologies from Councillor Edric Hobbs, and no substitutes appointed, and other members who are not present have not given reasons why they are not here. Thank you.
Item 3 is declarations of interest. This is why I invite members to declare any interest and make them aware that the list on the council members' personal interests as members of district, town and parish councils are available for inspection on the website. And the second thing that I've got, because I'm trying to rush this, I'm so sorry to get to the main business because I'm so excited, I've forgotten the minutes of the last meeting. And Jack is now going to beat me for that. So I want to approve the minutes of the meeting, 14th of May. Everybody happy with that? Yes. Councillor Bailey.
Thank you, Chair. John Bailey, Martok. I did raise a question with.
Push it down, sorry.
Bring the cameras in. Thank you, my assistant is very helpful. About the relationship between the new, it was in relation to the NHS presentation about cardiology in stroke in Yeovil. I raised this that I'd asked for an out of meeting clarification of the relationship with the Yeovil Heartbeat and the health services, the health gym set up, rehab set up that they were talking about there. I've received none. So could we move that forward or make sure that's addressed?
Yeah, yes, we certainly will. We'll look into that. We'll look into that for you and get that addressed, and I'll come back to you personally if I may. So, okay.
Mr. Ridsdale, I think is his name.
Yeah, I'll do that. Councillor Oakes.
Just to say, if we ever get to a situation where we are talking to a heartbeat, after I had my heart attack, they were excellent. They treated me, so I definitely have at least a personal interest.
Well, Graham, can I just say that if you've had a heart attack, you look remarkably well, and I'm very glad that you're here. So thank you.
Is the effect of coming back here, Chair?
It would be. It would be. Thank you. Thank you. Are the committee happy with the minutes, please? Everybody happy with the minutes?
Yeah.
Thank you very much. Thank you. Declarations of interest, I think I've asked. I don't think I've had any. Item 4 is public question time. I don't think we've had any public ask any questions. None have come through. Sorry. Was I distracted? I'm so sorry. Sorry, Jay, could you repeat that? I apologise. I just public question time. We've had none come through verbally or nothing like that.
Yeah, no members of the speak.
Thank you very much. Thank you. Item 5 is the Adults and Housing Scrutiny Committee outcome tracker. And this is where, Jack, just if you don't mind, I'm sure the officer won't mind just calling him Jack. I get his surname wrong all the time. To present the outcome tracker, please.
Thank you, Chair. Yes, this is the first time that you have in the outcome tracker in this form, the format of the outcome tracker for this committee and every other committee, other scrutiny committee is exactly the same. The outcome tracker before you is going back to the beginning of this year. Any other action previously had been already undertaken and completed. I'm happy to take you through the actual format of the outcome tracker, unless you want me to leave it to you and to committee, you know, to continue.
No, I'm happy for you to.
Okay. The format of the outcome tracker is that in the first column, you know, you will have your date of the meeting and items that were on that agenda. The lead officer and member are also registered, you know, for each item. The agreed outcomes then were listed in the table with an update below what had happened since. So whether the outcomes that you have, the recommendations that you have made have been responded by executive lead officers or colleagues, you know, from NHS and other partner organizations. And then as the last one is RAG status, which gives you where we are, which actually when it's green, you know, that means it's completed. We can take it off from the outcome tracker for the next meeting. Those in amber and red are yet to be actioned as well. As I said, this is the first of the outcome trackers that we presented to this committee. I will not go through each ones unless committee members and yourself, Chair, would like to discuss specific items. Thank you.
Councillor Turner.
It's not a specific item at all, but I really like red and the green style of it. I think it draws your eye to the things that you most need to see, which are the things that are outstanding. So just wanted to thank you for your work on it, because it's really good. I like it. Thank you.
Councillor Bailey. Just Councillor Bailey.
Okay. Are we going to look at the items on the tracker?
We're going to look at the red items on it, definitely. Yes, that's already come to that. Councillor Oakes.
Thank you, Chair. It is the sole red item was that you were going to write a letter. It says that's been drafted. I wonder whether we had a kind of guide date as to when that letter will be written and sent.
Yes, thank you very much for that. Apologies that letter's not gone out. We've been waiting for some further information to see whether we were going to have a better funding, but it doesn't look like we know anything. So what we'll do is we'll put that letter together, and if you're very happy for us to just send that out, unless you need, I'll check with my vice chair as well to make sure that he's happy, and we'll get that letter sent out on behalf of the committee. Is that okay? Yeah. But we're always hopeful of changes, always hopeful of anything improving, and doesn't appear to be. Councillor Oates.
And to check, is that a typo? Should it be local members of Parliament? Because the public health grant obviously covers the whole of Somerset. So it should be going to all the MPs, not just.
I think Councillor Evie Potts wanted it to a particular. Oh, sorry, I can't see you. Yeah, I think you wanted it to particular. Or did you want it? Is that my recollection? You wanted it to a particular member of Parliament?
Sorry, can you?
Sorry. Did you want the? It was agreed that the chair and the assistant officer would write to the local member of Parliament. And at the time it was mentioned the local member. But I think Councillor Oakes is quite correct. I think perhaps all members would be good.
It clarifies that all members, because Somerset Council, they are all Somerset MPs, aren't they? And it'd be good if they're all involved. Thank you.
Thank you very much for that clarification, and that will be done. Okay, thank you very much. Anybody else on the tracker? I think it is very good work. I think that there are a couple of things that we need to look at, and And they are, I have got them, but as no one's mentioned them, I won't take time. But there was a couple of other items and we'll get those soon too, okay? So thank you very much, thank you. Item 6 is this is to the access to general practitioner GP surgeries. This is something that we've all been very concerned about. And I'd like to welcome NHS ICB colleagues Sakina Kazem, Luke Best and Sam, please forgive me, Shekovich to the meeting. Oh, good. Getting better. And obviously, if you can present this report, and then we will allow for members to ask questions afterwards. Thank you. Sakina, if you want to start.
On the side, looking there is a power button. Yeah, yeah.
It has to be red, that's right. Yeah, good.
Right, so, good morning, everyone. Sakina Kassan, Director of Primary Care, and just appointed as Deputy Place Director for Somerset this week.
Oh, congratulations.
Thank you. But, in my current role that I'm transitioning from, obviously, we were requested to come and talk about primary care access. So mainly around general practice access. We've prepared a presentation. Did you want us,
Yeah.
did you want to?
Can I just come back to you on that? We particularly asked for access to GP surgeries.
You did.
We wanted it specific.
Yeah.
The primary care
They're going to give you some context about the facts that we've got. And then if we take questions as we go through. Thank you.
If you could, let me just ask, can you all speak near the microphones at all times, please? Because people online do have a bit of a problem and it's just helpful because they want to hear everything you say. Okay, thank you.
Morning, everyone. So as Kenna says, yeah, I'm Luke Best, I'm a primary care manager at the ICB. So I'm going to kick us off by talking about some statistics that we've got access to around GP access. So I think it's fair to say that these statistics are the best that are available to us. There are some limitations to the data sets which we've got, and that comes because all their individual practices and the national data extractions are based on how good the coding of appointments are at each individual GP practice. So to kick us off then, so 80% of people, this is via the GP patient survey and an updated NHS England survey, which has just been released. 80% of people find it easy to contact their practice in Somerset, and that puts us in the top 5 nationally consistently and has done for the last sort of 6 months to a year. 85% of appointments take place within 14 days, and to break that down a little bit further, of that 85%, around 40 to 45% are same day. And as I expect you all know, there is a focus on same day access at the moment from a national or government perspective. That leaves around 15%, which take place longer than, after 14 days. And there are a variety of reasons for that, quite plausible reasons and sort of fair and reasonable. And that could be patient choice. So they've chosen to wait for a clinician of their choice, which takes them beyond the 14 days, routine blood tests, where it's been clinically appropriate, so they've been triaged and they don't actually need to be seen within 14 days because it's not necessarily urgent. So as I mentioned, we're above national average for the overall patient experience in Somerset. And what we're doing at the moment as part of the ICB restructure is pulling together and triangulating all of the data sets that are available to us into one place so that we've got a clear and accurate picture, or as accurate as possible, of what's going on in Somerset, and then we can use that to inform sort of commissioning decisions, how we support our individual GP practices, etc. Next slide, please. Thank you. So that brings me on to sort of the GP contracts. So the current GP contract has a couple of access metrics within it. And I'm pleased to say that all of our practices in Somerset are 100% compliant with those contractual requirements. So an example of those is that they are all open during core hours. So core hours is 8 o'clock in the morning till 6:30 in the evening. And that they've got access for all patients via both the telephone, online consultation platforms such as Ask My GP, Anima, etc., and by walking into the practice and speaking to a receptionist directly. As part of that, there's a modern general practice element which has been introduced about sort of 2 years ago, which we've been working on. I think the last time we came here, we spoke about this, and we were right at the start of the programme then, whereas now we've moved on considerably. And as part of that, all practices are now on something that we call cloud-based telephony, which means that they've got things like callback functionality, so they don't end up being sat in a queue for, say, half an hour in the morning at 8 o'clock. It means that they can press a button and the GP practice will call them back as soon as they reach the front of the queue. It means they don't have to sit on the phone waiting. And as part of that, we have now access to a national data set, which gives us an indication of how long people are sitting on the phones, the volume of calls that are coming in, a variety of metrics, which mean that we can use that data at individual practice level to start remodeling appointment books, staffing levels, etc., so that they've got the right staff on duty at the right points of the day. It's a really powerful data set actually, and it shows you sort of the patient journey and what's actually going on at individual practice level, because we all hear individual stories from people that say, oh, they sat on the phone for 45 minutes. This data actually enables us to see which patients those were and rectify and remodel appointment books appropriately. So moving on then, so what do we actually do to support individual practices? We've got something in Somerset now that we've set up that's called the GP Support Unit. The clue's in the title in that they support GP practices in Somerset, and they are now leading on provider resilience, so supporting individual practices, looking at sort of, like I say, their telephony data as an example, and actually really drilling down into the detail of what the problems are at individual practice level and how are they going to fix those. And that's a team of people alongside the ICB that will go into those individual practices and have those conversations using the data that's available to us and meaningful patient stories to actually enact change. I think that's something that we've sort of seen a shift in the last couple of years, in that we've now got access to all of this kind of information through the national reporting requirements and the GP contract, the shift towards a more sort of digital way of working, which means that, yeah, we're seeing some significant improvement at individual practice level where we know that there have been problems previously. And we're hoping that over the next sort of year or so, that work will come to fruition. We'll start to see the benefits of that through things like the GP patient survey and the voices of the people on the ground that we all speak to. So bringing me on to the NHS app then. So there has been a significant uptake of the NHS app in Somerset. So 68% of all of our Somerset patients are now registered on the app, which is a massive improvement on 2 years ago, where we were sitting at about 35–40%. And that allows you to do all sorts of things, such as order your repeat prescriptions, book online appointments, amend your appointment if you're unable to attend. And it also unlocks a functionality where the GP can contact the patient directly and you can have a bit of a messaging service over the app. We're very aware that that's all well and good for people that are digital savvy, which is why that all practices still sort of maintain that level of access where you can just turn up to your GP practice and have that same conversation with a receptionist. But it's certainly a shift towards sort of a more digital way of working. And lots of our sort of voluntary sectors and other organisations that sit outside of the NHS support patients in making sure that they're able and are understanding the NHS app as well, rather than just sort of saying, here's a new app, on your way, you need to figure it out on your own. I find it confusing sometimes personally. So yeah, we're very aware that we need to make sure that patients understand how to use the app. So I think that's it on access from a GP perspective from me. I'm going to hand over to Sam now. Who's going to talk a bit more about workforce.
Can I just ask?
Yeah.
Would the members like to talk about the GP bit first before we go to access, or are you happy to hear the whole? presentation.
So this is still GP access.
It's still GP,
Yeah, it's just
okay.
related around the workforce and sort of the levels of
That's lovely.
GPs and the other healthcare professionals.
Because when we came last time, you asked us to bring back something about workforce.
Yeah,
So we brought something back.
thank you.
Good morning, everyone. I'm Sam Chekovich and I'm the head of General Medical Services, and I'm going to take you through the next few slides. So, as you will be aware, general practice won't work to actually see the patients. So, as you can see from the slide there, that we are above the national average, just slightly for 10,000 weighted population for GPs, which is very stable for us. The total number of GPs, again, has stayed relatively stable over the last year. And this, although we've lost some GP partners, mainly through retirement, that has been supplemented by an increase in salaried GPs at practices. So we're maintaining the levels of general practitioners. We have seen a reduction in the number of general practice nurses. Again, this is in line with national. But what we are working on in Somerset is a training programme where they can pool training placements across a number of practices rather than a practice having to try and train a big group of nurses in one go. And also with the opening of the Bridgewater College as well, and that will also help support our pipeline of future NHS and healthcare workers. So we'll be keeping a very close eye on these numbers over the next few years. Just to reiterate as well, the total number of GP surgeries in Somerset is currently 59 practices, and that's spread out across the entirety of Somerset across 13 primary care networks. And we also fund a relocation scheme to encourage uptake from newly recruited GPs and nurses to move to Somerset from outside of the area. Because we're very aware that we don't have a nursing school at the moment like UWE or down in Exeter, Plymouth Way. So kind of miss out on those newly qualified. So we've got a relocation scheme to help encourage uptake. And it helps when practices are obviously recruiting, putting their adverts out if they can offer something like that. Next slide, please. The national model ratio for patients is 1 GP per every 3,500 patients. We have got 4 practices that outline this, but three of those practices are at Symphony Healthcare, which is our at-scale provider, and they run a slightly different MDT model. And the other practice is also an at-scale provider who run that same MDT model. So we're actually a high achiever. We're only 5% of an outlier compared to the national at 10% on that. So that's really very good. Other things we're doing, initiatives we're doing to help support the workforce and encourage workforce to remain in Somerset and also to come to Somerset is we have a program called Careers Plus, been running for many, many years now, and that's via the GP support unit that Luke mentioned in his section. But it's an established program where they support practitioners, and it's not just general practitioners, nurses, HCAs, and they've recently started non-clinical as well, so practice managers and senior operational managers as well, who may be at risk of burnout or feeling like they need to take a step away because it can be a very stressful environment to remain in healthcare through a coaching and mentoring program. The metrics from that we see from that from the evaluation is it is highly valued within Somerset, and we have anecdotes from members of staff who've been on that, that they would have definitely have walked away if there hadn't been for that support available. So that's another thing that we're doing. There's a national scheme called the GP Retainer Scheme as well. We currently have 18 GPs registered and we're fully utilised on that for this year. This scheme, it mandates protected time for continued professional development and also includes one-to-one mentorship. It offers financial and educational support to help doctors remain in clinical practice. And again, is often used by GPs who have taken some time out to have children and so feel like they need a little bit of extra help and support to remain in the workforce, but also those GPs who are perhaps looking to start winding down and work towards retirement, but it keeps them their skills up and keeps them in the workforce for a little bit longer. And new for this year, we've got the GP Partnership Programme. So this is a new educational workshop which has just been launched to help aspiring GP partners develop their understanding of business finances, revenue management, and we're hoping that will encourage more of our salaried GPs and locum GPs to take up those positions within partnership and allow that model to continue. We do need that pipeline as well to happen. And then there is also a new national, and it's brand new, it's only just started, GP reimbursement scheme. And this is to increase, help increase same day access. It pays practices to recruit a new GP or increase the number of hours an existing GP works to provide more appointments for their practice and therefore increase access to patients. We were also asked to talk to you about integration with other services and alternatives to general practice. And the main one for that is the pharmacy advanced services. And as you can see on the screen there are three main ones: Pharmacy First, oral contraception service, and pharmacy blood pressure checking service. Now, Pharmacy First is a service where patients can be signposted, can be referred by their practice, or can walk into a community pharmacy themselves for access to minor injuries, minor illness. But there are also 7 clinical pathways under that allow a community pharmacy to assess, advise, and supply prescription-only medicines to a patient for 7 clinical pathways. And they are uncomplicated urinary tract infections for women aged 16 to 64, acute sore throats, acute sinusitis, acute earache, impetigo, infectious insect bites, and shingles. So that allows access to patients in our 90 community pharmacies across Somerset without having to necessarily contact their GP practice. What we have done is for those patients who do contact their general practice for one of those items, we have invested in the digital referral system. And that means our doctors and our reception teams can refer a patient directly to their local community pharmacy or community pharmacy of their choice. We'll work in different places, so if that's more efficient for a patient, then that's absolutely fine. And then the community pharmacy will contact that patient time for them to come in. So we've done that for all of the services on the screen there: oral contraception and pharmacy blood pressure checking. Oral contraception service is relatively new. Again, for community pharmacy to continue the repeat prescriptions for a patient without them having to go to their general practice. They can also initiate new prescriptions for oral contraception as well. So again, it's providing access for patients in a different way. Doesn't mean that they can't, if they want to, go to their general practice. It just provides an additional option. And again, general practice can refer a patient, if that is the patient's wish, to that service. And the pharmacy blood pressure checking service, I'm sure most of you are aware of this because it's been a big service as a whole. Hypertension. So again, patients can be referred by the general practice to have their blood pressure checked within community pharmacy, and then the necessary interventions can also be made from there, either referral back into general practice or everything's fine. And the digital system as well, it means that the general practice gets the notification to know what has happened to that patient, and it can be there. Minor ailment scheme. Now, this is the locally commissioned service that was precursor to the National Pharmacy First scheme. We do still have that here. It does complement the services in Pharmacy First. So just to say, there is that as well. We also have the acute community eye care service, and again, patients can be signposted for eye ailments. They can self-refer. Then we have the community dental services. This one is just to say that we have allowed other health to. There is a criteria, so it's not any patient. community dental services with the need to see a dentist first. So it allows easier and quicker access to community dental services. And then just to finish off to say that as an ICB, we are looking at further transformation integration of pharmacy services with general practice. It's the logical thing to do. And as time moves on, we will get more services being commissioned nationally through community pharmacy. So there's a programme of work.
Just to finish off before we invite questions, I think it's fair to say we've given some stats and some information here which paint a positive picture. We are very aware that things aren't perfect. We all could sit around this table and talk about personal experiences of ourselves, our neighbours, etc., where things haven't perhaps gone quite so well. So what I wanted to do was a bit of an ask, really. Patients should always be encouraged to contact their own GP practice initially to discuss concerns, particularly where they want to raise a complaint, etc., about the care that they've received. And the reason we say that is because actually it enables a quicker response, and the people that are actually dealing with the care can look into it. But however, alternatively, the PALs and the complaints team at the ICB are always very happy to speak to patients where they don't feel like they can talk to their own practice because of breakdown relationship, etc. So I just wanted to include the details of the ICB's PALs and complaints team here in the presentation for circulation afterwards, so that you can all give that to constituents and patients.
Thank you very much for that. Before I go to members, if members won't mind, I got a bunch of questions I'd like to get on, okay? Because I've been waiting for this, and I think it's like, I can ask the naughtier questions perhaps. First thing I'd like to say is Somerset is predominantly a more mature area, and I don't want to hear that we're the national average. I want to hear we're above. It seems to be with a little bit of complacency. It feels to me that we're happy just to be the average. No, we don't want to be the average. The app you talk about doesn't always get answered. Trust me, I know that. You can send a message that you consider to be really urgent on the app, doesn't get answered by the doctors because they're too busy. I'm going to ask these things and then you can come back to me. I wanted to know, why is there limitations on the data? I want to know why there is, because there shouldn't be. You've got 45% appointments on the same day. I wish that were only true in the real world. Sorry, I don't think that's true. 40% in 2 weeks and 15% don't even get 3 weeks or longer. Some people on this triaging, it's a good idea. I get the weeding out, I get that idea. But sometimes some people are very modest and they don't want to tell doctors how really bad they are. And then you've got the others that don't live in the doctor's surgery all the time. I know that's not easy. The other point I wanted to ask is there are no walk-in doctor's surgeries. You've got walk-in. I can't find one. I can't find one where you can walk in unless, with the greatest respect, you had a bullet in your, and then they were saying that maybe you need some help. But I don't think they just got the capacity. You know what I mean? They probably want to do it. We've got 399 in March 2026 GPs, but we're down on nursing staff. Again, I think 59 surgeries in the whole, is that enough? Right? The other point I wanted to say was that do you believe that the transformation of integration of pharmacy and general practice is working? I don't necessarily get that from people. So my questions really were about things that people say to us. And we are hearing people more and more saying they're waiting and waiting. And the inequality issue as well, about the patients who have to press 1 for this, press 2 for that, press 3. It's just not really good. And not all patients are online. We seem to we're not finding a way through of looking after the patients who have no idea about what an app is. They think that's in space. And with the greatest respect, they just don't want to know. So I think we need to be very, very careful that we're going very digital, but we're not looking after lots of people. And they're not only older people, some younger people don't want it. So I've given you a bunch of questions to start off with. No doubt you'll get thousands more, but if you could just answer them, that'd be great.
With that.
Yeah.
So, when you said about average, we're not average, we're above average. So, just that's the thing, we're above average.
We're above average.
Yeah.
Average. I hate the word average.
Yeah, but unfortunately, we have to have some sort of metrics to do some baselining and measuring on. Just that. You mentioned something about urgent, so, patients are not encouraged to message any urgent queries through the NHS app. So where practices, or their staff pick up on any urgent queries, they do go back to patients advising and the support, organisations also know that patients shouldn't be messaging any urgent queries through the NHS app. It's not designed for urgent queries.
Can I just say to you that on the app I have, it says if you wish to send the doctor a message to ask the doctor a particular question, you can. Doctor
Yeah.
never got it on the app, never got it.
Okay, so, and this is the reason why, obviously, there will be, incidents when there are issues, etc. And we would be asking for that to be investigated by the practice or come through to our house team so that we can help. Because sometimes, there can be genuine reasons for why a message didn't go through, and then that can be investigated. But that's the reason why we encourage patients to make contact and feedback, patient carers, their families. Question was around the same day access. Do you have any more questions?
Yeah, just gonna say, so, but on the same day access, obviously we said 40% there. That's 40% of appointments that took place. And this is what I was talking about and feeds into the limitations of the data set. We don't know what the unmet demand is because there's no way of measuring that. There is no reporting system for that. So we can only measure the appointments that actually physically took place. And that's why we're saying 40 to 45% of those are same day. I think it's a national issue in terms of not knowing what the unmet demand is. And that's something that NHS England are working on to get access to that sort of level of data or work out how to get access to that sort of data because you don't know what you don't know kind of thing. And just to pick up on the walk-ins as well. So it's not a walk-in as in you walk in, you can be seen there and then. It was just another method of access like telephone, online consultation systems are. So you would be able to walk into the practice and say, look, I've
But that doesn't, if you say something, walk in feels like you're going to be seen. So maybe you need to just change that wording. Is that all right?
Yeah.
Okay.
And there was one more point you raised around triage. In the current day and age and with the demand on healthcare services, there would need to be some form of triage at the front door. Otherwise, it would be very difficult. And if they didn't do triage, then we wouldn't be able to prioritise the ones that needed.
Yeah.
It would be just unrealistic if we didn't have a form of triage system.
No, I do agree about the triage. I think it's, we have more questions, but I'd like to go first of all to councillor Bruce and then.
I think I definitely was the first.
I'm so sorry, I think I've lost it.
I think it was.
Oh, well, listen, let's not fight about it. Councillor Power then, come on.
Thank you. Well, I think I might have to declare an interest actually, because I sit on a education group. So just that one from them, really was about that. Just regarding the number of GPs that you've got, have you got a figure of actually how many are that are actually based there or that are they locum? How many locums have you actually got? Somerset, because when I was starting the PPG, we struggled to get a number of GPs to come to our practices. So we were going through a number, and I mean a number of locum doctors. So with the figure that you've given us, how many of those are locums?
You on that, Tom, because I don't have that to hand right now, but if you'd like me to, I'm absolutely happy to see if we can get presentation for you.
That sounds like action. But when you talk about Symphony, don't forget you sit on a group model, which is very different. And as we alluded to, Symphony does have a very different model. So we have a list of GP partners that hold contracts. We have GPs that hold contracts and work in their practice. And then the way we would hold the data is a whole time equivalent. So what we've got to remember is counting heads isn't going to actually tell you how many sessions or how much they actually work. So again, it's about how you interpret the data that we give you. But happy to take it offline and take it as an action. Yeah.
Councillor, Trivial.
Yeah, thank you all for your presentation. So I have a couple of questions and then I have a wider point to make, and I hope it's okay to make it. So, firstly, alternative repeat prescription ordering methods. I wondered what they were because I use the app. I deliberately saved using the app today till you were here because I knew it would jog my memory. And also just to check a particular feature which is really irritating people and it's a problem for me, this one-time passcode system. And you can click a button that says, don't you remember me? And it never does. And if you're in an area of poor signal, or if it doesn't come through and you come out the app to look for it, when you go back in, you've got to start again. So could that glitch be solved? If you weren't aware of it, could it be solved?
I'm aware of it because I get this problem when I do it for my mum, when I'm in Somerset and she's in Harrow. So we can feed back to national colleagues through our local representatives around the glitch. And then in terms of alternative repeat prescriptions, well, what did you mean?
Well, because at the moment we can use the app. I use the app. It's marvellous because middle of the night when I'm going to bed and I take my tablets and I think, oh, I've only got 2 days left, I can do my order. So I think it's absolutely marvellous. But we do recognise that lots of people aren't able to do that. I know that our surgery, and I have to say, my doctor's surgery where I live is absolutely superb. Same day appointments when needed. I don't get any complaints from people about it. So I but there is that thing, you can no longer phone the surgery for repeat prescriptions. I just wondered what the alternative method was for people.
Yeah.
I have more questions.
Yeah,
There
should be an alternative offer, but Sam will answer. There is one. And again, I've exercised this for another family member.
Yeah, so the alternatives are you can have a counterfoil to your prescription that has tick boxes. So they can tick the box and you can drop it into the surgery. The other alternative is that your local community pharmacy can take over your ordering of your repeat prescriptions for you. If that is a method that would be helpful.
Okay, yeah, that sounds quite good because I did speak to a gentleman once on the doorstep who said that he didn't have a car, he couldn't drive a car, and so his son was having to drive 20 miles every couple of weeks to take that counterfoil to the doctor's surgery for him just to get his repeats. So it's just that I recognise this transition isn't straightforward. So
that service has been in place for a long time before NHS app ever came in. So it's probably just making sure that we're able to support our elderly or any patients that don't have access to cars, etc. And so you can go to a pharmacy and request for them to be doing their repeat on behalf of the patient. And normally that works quite well.
yeah, that's brilliant. I mean, it's just the lack of that phone service that probably people are very used to using suddenly. But that's fine. And I will be able to pass that on to people that the pharmacy can do it.
And normally pharmacies are quite good because they sort of monitor before they need to dispense for that individual. So they're normally really good at that.
Yeah.
Especially for vulnerable.
Yeah, well, that's really helpful, and it is really helpful because they'll know when those prescriptions are due as well. So, so no complaints, just little things that I'm flagging up. I noticed on here your GP retainer scheme. I wondered whether that was 18 GPs signed up to it or 18 GP surgeries signed
18
up.
GPs. I mean, human. Yeah.
And is that the maximum it can take? Could it take all of the GPs?
Well, it can take more retainers. So in terms of retainers, the idea is that we're trying to keep people in the job market and so that we don't lose people. And once you lose somebody to another area, you're not going to get them back. And as we all know, workforce and retention in Somerset, especially for clinical staff, is an uphill battle. So that's the reason we look at all sorts of initiatives to support retainment, but also to attract people to come and work here. So some of these schemes are very local schemes that we've invested in through the funding that we have.
Okay, and then finally, the access part. This is where I see a problem. So I had somebody speak to me the other week. They're a doctor's surgery. They were invited through the app to go and have their diabetes checked. So they phoned up the doctor's surgery and said, you have to do that in the surgery. 5 miles away. So they booked the appointment. They were told they didn't have to have any tests beforehand. It was all done there. They got there and they said, well, we haven't got any blood test results. And they said, well, like you said that you would do it here. They were told their eyes would be checked and their feet would be checked. And they don't do any of that at that. It was just a review. So then they had to book back. When they went to the reception, they were told, no, you need to go to your actual surgery to do that, to book the appointments. They went out to the car, booked the appointment, and it's a waste of appointments. And so I just think where these things, where you're sharing services, and I understand there's a need, there needs to be some real clear directive as to how people need it, how this is dealt with, and also just some thought about people who can't get from one place to another, because in rural areas our bus service is very patchy.
That's a really good example of when something operational isn't working. So it feels like the diabetes example that you're giving us is because skill sets can be quite rare, and to make sure that we're using workforce accordingly. Deliver a lot of long-term condition sort of care together, but it's examples like this. If people are experiencing them, they need to let us know, because it could be an operational training issue that we need to pick up with the individual practice or the primary care network. They've sort of set something up and not realizing that this is having a knock-on effect. That's actually 2 appointments wasted.
Yeah.
So again, it's something that we need to know about. So it was quite helpful to know that, so we can go back and then support the relevant.
So is that to go back through PALS or somebody like that, contact the surgery? And also just perhaps those services could rope, if that's the case, so that people can go on a Tuesday to their own surgery or on a Wednesday to the surgery neighbouring.
And there are different models across the 13 PCNs. So some have roving models, some don't, for various reasons. Sometimes it's to do with staff contracts or how staff can get to places, etc. So there are different models across. And so we hold the contract. We do, and we sort of guide and advise, and they all learn from each other sometimes as well. So we have recently also GPSU have now got regular learning where they are piecing together and best practice models, etc. So but that particular example, we're happy to pick that up with you directly.
Thank you, I'm done. You'd be pleased to know.
Oh, well, I just want to say one thing. My surgery, you phone in the afternoon if you want prescriptions. I do use the app. How lovely is that?
So
They don't all do that, do they? That's the problem.
So there are practices that will accept telephone requests for repeats as well. So there will be patients that they will know that they have to do telephone. It depends on the practice and how they do it. But it is something that, you know, you'll have vulnerable, sometimes end of life patients, etc., where families will want to be calling in and they should be known. Also,
I think consistency would be really helpful. That's just one word I'd like to say. Can I now go to Councillor Govia, please?
You can, Chair, but I didn't actually ask to speak.
It's okay. Just hang on a minute. So.
Yeah, it's Andrew Goby from Wellington. I just wanted to say to thank the presenters for their presentation. It's quite interesting, and I was pleased to hear what Luke had to say about because I use the app and I find it very helpful. But I think obviously it's a generational thing that you touched on, that some people don't, and I'm pleased that some thought has been given to the 32% or who don't use the app, because it is that group of people, and they have to use it, the old fashioned turn up at the surgery and that type of thing. And I think that still gives the impression that the service doesn't work as well as we're hearing it does now. So I think that it's just really to say that, welcome the fact that the app works so well, and access to GPs, I think is improving. I think people still say a generational thing, go back to the days when they knew the GP, they saw the same GP all the time, that sort of thing. And that's the sort of thing that's changed. And I think younger people are used to that now and don't worry so much about seeing it. So I just think it's I think you touched on it. Things are evolving. And I think Lucy said the same. These things can't happen
overnight, but I think it is, you know, the definite signs of improvements, I think, across the board.
Actually, Sam's just reminded me, you made a good point. So one of the reasons why they don't use telephone, is there is a reason around governance for this as well. So it's very exceptional in terms of telephone requests.
Yeah, so just to provide you with the information why telephone requests for prescriptions are not usual and is not the normal process, is because you can't tell who you're talking to. And not everybody has their counterful, so knows exactly what they need. So you get a lot of phone calls saying, can I just have my blue pill? Well, that could be a number of pills. Things could be, no, that wasn't it. To me, like any other kind of way. So it's actually a safety issue, and it was actually back in March 2006 that the governance changed on taking telephone requests for prescriptions. So Joy, you're very lucky that your surgery does still.
But can I just say, my surgery always says name, date of birth, do you have your NHS number? They always ask that to make absolutely certain.
Yeah.
And then, would you believe it or not, they go on a computer and they actually can tell you what you've got.
Yeah.
Which I think, and I do think that would help if that was consistent across the board. I just think that's worthy of
Yeah.
saying.
But it's just to say, it's not an arbitrary decision to take, not to take telephone requests. It's actually a change in the process and guidance for prescriptions, that they should be by exception and not safety perspective. So, but they will always work with patients to say, if you are somebody who is vulnerable or you have no other way, make that relationship with your general practice, and they will support you in making sure you do get your prescriptions. So whether that is through telephone or whether that's through a pharmacy managing your repeat prescriptions. Yeah, just remind your patients to have that conversation.
I must be very lucky. Councillor Brooke Bailey.
Thank you, Chair. Thank you for your presentation. John Bailey, member from Martock. I've got a point of clarification. You mentioned the 59 surgery partners. The other date on that slide you compared with 2025, is that because it's just the same as it was in 2025? There's been no change? Or has there been a change?
And so the 59 are practices.
Yeah.
Not partners.
Yeah, so it's practices, but it has changed from last year, and I think in your area particularly, you'll know that there's a current merger happening between the surgeries in South Paddington, Martock, Kruger, etc. So that will change the figures that are presented. Okay, there's 59 practices at the moment.
And then we have branches, so there'll be sites as well. So sometimes you might have one practice, but they might say one practice contract, and they might have two sites. So, and we can provide that data as well. So there are different numbers of sites as per contracts held.
I suppose I wanted to figure just compared apples with apples rather than apples with pears, really.
Yeah, so there will always be a change in that data,
Right.
depending on how many contracts are being held.
Okay, so it needs to be clear that based on which the data.
Yeah, we can provide you with that.
Thank you. The other thing was about a lot of the comparisons with national data. And obviously, I think it'd be more useful, this may not be possible, to compare it with data of relevant positions in the country, like rural positions versus urban positions, to get an idea of where we were really, because I think that's what we need to compare with. So that's just a point really I'd like to make in terms of future data perhaps. But it brings me on to my third perhaps the substantive point, which is about access really, and I think it's in relation, I have to mention because I forgot that I do sit on the Symphony PPG local in Martock when I can make it. So I should have made that point earlier on. I hadn't realised that. Apologies. But it's about a lot of these, and you mentioned about the combination that's going on, the changes that are going on in Symphony there, which I won't bore everybody else with. But it's about the access situation. I think the access word came up again and again, and it's critical. It was mentioned by other members as well, because decisions are made about these changes, which I'm sure are made in terms of efficiency or productivity or whatever. They don't really take account of access. I'll give two examples which are historical. Just as a sort of an example, when the situation changed at South Petherton some years ago, there was no way people could access the change of the surgery out of the town village rather into next to the hospital. What we had to do was extend the bus service, the 81 out to there, but no thought was made of that at the time when the decisions were being made. That had to be made subsequently in order to dig it out of the situation. And that fund, that extra layer of that bus, it's not very long, but it creates the access, has to be paid for by Somerset Council.
I think we're slightly digressing, councillor Bailey, if I may, about the bus service, because it's not really in their remit, but
Well,
I mean,
It is
it's
about
a point, but you know.
I was using it to
Explain.
example and explain point. I was going to give another one, but it's more recent. Again, Somerset Council has to fund a bus service because of decisions that were made. But I won't go into that detail as the chair won't allow me that time. But coming back to the access point, in the current movement, sitting on the PPG, I've been told that people could go to Crookhern from Martock. There is no bus service, so I'm going to come back to bus service. It is about access. So sorry, I'm banging about the same thing, Chair, but I will continue about that. It's a rural situation. And so it'd be great. I could go to Crookhern, I've got a car. But the people in the demographic that we really have to be concerned about, who haven't got cars, can't do that. And I don't see it once again, and I was going to give 3 examples because I thought it would identify historically we're going around the same boy here. But it's happening again, and there doesn't seem to be any thought about how people would, in fact, if they wanted to take an appointment in Crookhern, get to that appointment.
So, but sort of answered it yourself in what you said there in terms of if you can get to Crookhern, you will be offered an appointment in Crookhern. Say, we've had this conversation with Symphony time and time again in that patients will always have the choice as to in that now one primary care network first site. So if they were previously seen at Martock, they will always be able to be seen at Martock. There will be no stipulation to say you must now go to Buttercross in Ilchester to be seen. And yeah, there's no sort of favouritism of you can get an appointment sooner if you go over there kind of thing. So yeah, just
Okay,
well, clear about,
thank you, Luke.
need to be clear about that.
Yeah,
I have asked the question before and I've been told the opposite answer,
yeah, so
but.
the approval was on the basis of that. So
Yeah.
that played a big part in the committee approving the merger.
Thank you, Chair.
Thank you. I'm sorry, councillor Bailey, it's just that you could do most things, but not everything. But any influence on the bus service obviously does, would help. So councillor, can I go to councillor Bruce now, please?
Thank you. Hi, yeah, Councillor Bruce from Bridgewater North Central. Thank you very much for the presentation today. I appreciate why you've come to us with average figures, but my concern is that we can't really scrutinise what the situation is without some more detailed geographical figures and understanding information about the differences geographically, or whether it's for different groups of people, rural areas, which practices in particular are suffering. I've got a few points. I'll just go on before you answer. I did appreciate the reference to difficulty in getting the data because of the different practices. So I'm not sort of saying why haven't you come to us with this, but I understand there's reasons why. I would like the committee to understand more what those difficulties are and what's being done about getting that data, because until we can understand where the hotspots are in Somerset, we can't really understand what needs to be done to help to resolve the issues. There was also mention about the cloud phone-based systems, about you've now got data on phone waiting times. I would like to see that if possible, please. Other point which you talked about staffing, talked about the trying to recruit nurses in different areas and the fact that we don't have nursing school here, so it's difficulty, but there's been, if I understood correctly, about 6% reduction in nurses in a year. Forgive me if you mentioned it, because sometimes verbally I don't take everything in, but could you just clarify if we know why that reduction has happened? I understand we're trying to recruit more, but why have that? Is it partially because some services are moving to pharmacies? Is it wanted, not wanted? Just unpredictable, that's one thing. And then the last thing, sorry, I'm just putting on. capacity planning. So again, it's kind of like, I'd like to understand which practices are under the greatest pressure today. But I also want to know, which ones are going to be expecting to be constrained in the next few years and how we're planning our GP provision for the population growth and where housing is going to be, because at the moment, housing pressures in certain areas, I mean, I'm talking about, obviously my knowledge is more about Bridgewater, but I know there are many other areas in Somerset that are under quite a lot of pressure. Lots of new housing going up. And what is the planning for the future provision and capacity?
So I'll take the data question first. So there was a reason why you've got very basic presentation from us. We were requested to come at last minute. So the request came through quite late, and I did explain that my team are under a considerable amount of stress through the restructure. So I did advise that we would come and speak and listen, but we wouldn't be able to bring all the data because at the moment we're going through a considerable amount of activity in the restructure. So that information is available, and we have offered to bring that in September, October time.
I'll just come in on that point as well. I think recognise that you all look after different areas as well. I'm not sure it'd be a best use of time here to sit and trawl over the in-depth data of individual areas and practices, etc. But very happy to pick up on offline conversations with any of you if you've got concerns in your areas where we've got access to that sort of localised data.
Sorry, I do need to come back on that. This wasn't definitely a thing about parochial. As a committee, we need to look at the whole of the county of Somerset, but that does mean looking at where the problem issues are. So we do need to get into the locality of it. It's not about being parochial in our area.
That's fine. Yeah, we can bring that data. That's fine. We can share it with you as soon as we've got and where we would know that there's any issues with the data, etc. We would let you know. And if we knew of any with a particular practice, we would need to sort of let you know about that as well. Because sometimes data is as good as what you put in it. You only get.
Thank you for explaining that.
Yeah, we're happy to bring that. Nurses, I think Sam was going to answer that.
So it's actually age related. So, and this is a national issue. So our general practice nursing staff is actually on the older range, which is why we're trying to encourage additional training places for nursing, not just general practitioners, and also with the Bridgewater and nursing college as well. That should hopefully help. The other thing that also happens is when they are training, there aren't that many available general student nurses, so they don't actually know what the career possibilities are. When nurses come into general practice, it's usually on when they're sort of mid to later career. So it's not for any reason other than actually they've reached the age of retirement. We do have an aging nursing population in general.
And that's the sort of thing that we look at in terms of planning. So when you were sort of saying, how do we look at workforce data, etc., and I'll move on to estates in a minute. So this is just an example. So if we've got 59 contracts that we hold, we'll have GP partners on those contracts. We look at their age and everything, and we go in as a team to start talking about exit planning, if they're going to be retiring, who are they going to be handing over to. So it's around the survival of that service and contract, but also how we're planning for that. So when we're looking at workforce retention, etc., we are looking at workforce planning as well, and we're not looking at that in silo. We work with other partners, so local authority and voluntary sector, etc. So it's looked at across Somerset. Stakeholders and obviously sort of things like part of the decision planning to the estates bit as well. So where you were talking about housing, etc. So we're not saying that we're perfect at it, but we are working towards improving this as well. So we've been doing work in the last 2 years around just baseline data on our estate. So it's a complicated infrastructure. It may look very simple in the public eye, where you sort of look at a building and you think that's GP practice, it belongs to the NHS. It doesn't, because they're all private owned businesses. So, and there are different models in the estates world as well. So some practices are owned by partners, some aren't, some are property services, sometimes they're NHS property services, sometimes they're private estates. Housing development, so we're working very closely with Somerset Council around the housing side of things. There is, we have estates team within our team, and in the new structure, there will be an estates team as well. Not looking at general practice estates in silo, we're now looking at this as a system to look at how we work with the local authority ourselves, and we make best use of estates that's available to us, including public estate, etc. So there is work.
Do you mind if I just very quickly? In that case, I think it will be really useful when you come back to us later on with more kind of detailed data, to have a bit more information as well on that.
We can bring back general estates data, or I can bring back estates colleagues to sort of sit at the table.
I should have said before this meeting started that we've asked you to come today because it's very, very prevalent at the moment about doctors' surgeries. But what I also thought it was good today is that you're hearing from everyone, very, very pertinent questions.
Yeah.
So when you do come back again, and I do want you back again, all of you, I think that will help us, because we want a deeper dive. We want a deeper dive into hearing. Yeah. So this is why I think it was well worth coming today. So I'm now going to give you to somebody else, who's Councillor Oakes.
Thank you, Graham Oakes, Yeovil East. Thank you very much for the presentation. Just say that I help Lucy and people. A nurse in my surgery put me on 2-month prescriptions. I didn't know you could do that, and that is so much better for me that I get my meds in one hit. And also a little plug for Tesco in Yeovil. On Sunday night, I put in my monthly order. I do it a week to 10 days before my pills run out. On Monday lunchtime, it was ready for collection. Now, they're not always that quick, but that's what we need to aim at. Moving to your report, 55% of patients don't get a same day appointment. That's failure in any other area of work. If you turn away 55% of your customers, particularly ones who, that actually is a failure. If they're not actually getting the appointment, and I accept the triage. As a nurse, I fully understand triage. What is the contractual target for same day appointments? What percentage are they meant to achieve? I accept it wouldn't be 100%, but 45% sounds low. Does this have a knock-on effect on male patients? We have a problem in England with male patients being reluctant to get treatment. Does this, I can't get an appointment, give men another excuse not to turn up? Does the contract cover just Monday to Friday? Is there any obligations with contractually that they should have a Saturday or a Sunday service? I can see the heads and think I'm going to be disappointed. The relocation scheme, is this brilliant idea? Was a beneficiary many years ago. Is this essentially like the Whitley terms that apply to NHS staff? Because these aren't NHS staff, where you get support to relocate to an area. No, I'm going to be disappointed again. Nurses generally are older when they go into GP practice. There's a reason why we all get carried away with the exciting stuff when we're young, and then we move into different areas, and we're attracted by better working hours and things. Can I ask, are you picking up any issues at the moment following the BMA's recent attack on advanced nurse practitioners? In other words, the doctors have declared war on the nurses. Is that affecting our position about, are we getting any feedback from that? Thank you.
So we'll start with the first, round, same day appointment. So the national contractual obligation is any patients making contact that's clinically appropriate, which is the magic words, to be seen same day, need to be seen. But it's got to be clinically appropriate and the target is 90%, but was it this April, it was
Yeah,
April
that comes in from April 2027.
7, so
So now it's what?
So
So
there isn't.
There isn't.
there's no actual threshold, but contractually, they are supposed to see those that are clinically appropriate same day, but that doesn't mean that, so when the patient is presenting at their GP practice, they're not all going to be clinically appropriate to be seen on the same day. So, I don't particularly agree with the, with the challenge around, the appointment.
can I just say, if you have pain, the only person it matters to
Yeah,
is the patient.
Yeah.
We cannot judge that. We
Yeah.
do not judge that. And we don't know if somebody actually has something serious if they
That-
talk to a receptionist. And, you know,
that's,
so,
that's the reason there's clinical triage. So it's not the receptionist that's doing the triage, it's a clinical triage. So if you have pain, you go through a clinical triage to determine if your appointment needs to be a same day appointment.
And I think that's the only way that you could, is there any other questions that got to be answered?
Oh,
Beg your
yes.
pardon, sorry.
Yes, there was. The next question was, so we
Men.
talked about,
but men,
yeah,
basically, we have a problem in this country that men are not good at, getting involved with their
Yeah.
health.
like my husband, yeah.
And I'd say all of
And
us,
he's
to
a
be
doctor.
honest. Yeah, even worse if they're doctors. Is there any evidence in Somerset that actually the difficulty in getting an appointment just prescribes another, presents another opportunity for men to say, well, what's the point in phoning? They won't get an appointment. It's another, have we done any work on that?
If I'm going to be honest, it's not something that we've gone looking at. But I think this is something which is anecdotally known to all of us, that there are certain groups that need encouraging and pushing, which is the reason why we do a lot of prevention and targeted public work. So we do a lot of work around communication and engagement with the public, and normally that's what we do our targeting around. So we do use population health data sets and outcome data sets to inform where we need to do our public campaigning.
I think there's a good opportunity as well there. So they do something similar with the farming community.
Yeah.
Because they're so raw, so far removed. So yeah, I think, yeah, it's a good opportunity there.
Yeah. And if anybody does have any sort of ideas, etc., we do tend to engage and with the public on that.
I think the media has been very good recently about men. I think
Yeah.
that's really helped a lot of people.
Yeah, so we do get national directives and national comms, where, normally, you know, so for example, we know there are some cancers, etc., where if they were early presentations, so there's a lot of national campaigns that then come down locally. So a lot of that campaigning work that we do, that our comms team support us with, and actually local surgeries and providers actually do themselves as well. So that you will see quite a lot of targeted, presenting early to things as well. That's where the national self-referral pathways have come through as well. So the self-referral pathways have been introduced for those reasons as well.
I just think we need to, time's running very short. I've got a question later, but I want to go to councillor Quiche, and then myself, and that'll be it. I think we've really scrutinised you very well.
I'll be very quick, Chair. Going back to what you said about training newly qualified nurses coming up on something. Correct? I think if you're starting out to see some sort of career progression. See that, because where's
That bit.
The other bit that you said was, phrase clinically appropriate. And I didn't quite pick up who decides whether it's clinically appropriate.
I pick up on your. Giving information. General practice is much more varied than that, particularly with the introduction, as Councillor Oakes was saying, of advanced nurse practitioners, nurse prescribers. If you're a student nurse who hasn't had the opportunity to do a placement in general practice, you don't actually find that out. And then you can specialise in conditions as well. So a lot of general practice nurses will end up specialising in a long-term condition, diabetes, respiratory, and that also provides a career pathway, which is why we're trying to encourage training to happen in general practice, because those nurses who do a training placement in general practice actually love it, and they do tend to come out of their training and gravitate towards general practice, because they like the communication and the relationship that they built with patients, and they understand that there is somewhere for them to go from treatment room right the way through to advanced practice. And they can even go up to nurse consultant level as well. So there is a pathway. I think it's just not very well known. And so there's a lot of work, I think, for us and the new nursing college in Bridgewater to do, and for us to get training placements within general practice so they can experience everything that general practice bring to their career.
There was one more.
Oh, sorry.
Sorry. Made, which was around the clinically appropriate. You would need to have, so some practices, and in this day and age, there are some digital solutions that are available for clinical triage. But most practices have clinical oversight from clinically qualified staff to do the clinical triage. You've got to have a clinical qualification to do any form of triage. The nursing side as well, that you were talking about, so you can start off as a healthcare assistant and move into nursing from general practice. So in fact, the practice which I was a practice manager at many years ago, senior receptionist that we picked up from just her development, that she was really good. We started her on phlebotomy. She went into healthcare assistant. She is now a prescribing nurse in her career pathway and loves being in general practice. So it's just one sort of example.
Thank you. Thank you very much, Councillor Keach. I'm just going to say, I would like to say that this message needs to go back, that our GP nurses, I think, are paramount to a good running doctor's surgery. I mean, I got to be honest, I'm asthmatic and everything else. Don't see the doctor, don't need to, because the nurse can do everything. And if she can't do it, she'll find someone. What we need is more nurses in our doctors' surgeries to help the doctors. That's what we really need. And I think that message should go back. It was picked on a little bit earlier. Like I had a question here from someone else. It doesn't appear that GP practices are open on a Saturday. And I wondered whether any consideration, as going from Councillor Oakes had said, that maybe junior doctors or junior people could be there on the relief. Doctors can't go 7 days a week, I get that. But there seems to be with a multiplying population, we need to find a way. And many people who are working strange hours, can't get to doctor's surgeries and should be there, should be going. So I would like to ask that question. And I'd also like to ask, how do we compare with other areas in the south and southwest in terms of waiting times? Because I think that would give us perhaps a little bit more specific, and maybe you want to come back with that next time. I get that. But I do think consideration should be thought about weekends. I really do. So as you can tell, we really want a deep dive, okay?
Okay. Luke will tell you a little bit more about enhanced services. So the core contract, there are hours for the core contract, and then there's something called enhanced services for opening hours on a Saturday, etc. So Luke will explain that to you, but we can bring that back as part of a data set that we bring back around what the opening hours look like. So who does enhanced service and who doesn't. But again, it's opt-in and opt-out.
So yeah, in answer to the Saturday question, so the answer is yes, but not quite in the same way as you have Monday to Friday. So in the PCN, so that's the practice, the groups that the practices work in, there will always be one practice that operates a Saturday morning clinic there, and that rotates around the PCN. So yes, there is provision, but it's not in the sense of the general Monday to Friday, every practice is open 8 till 6:30. So just to pick up on the southwest point as well, Somerset are the best.
Yeah, well, I don't wish to be, I'm going to finish here, I'm going to round up now. I don't wish to be negative, but I think we want better. I think that's the message that we're going to say from every four of us. I think that's fair. We want better.
We always want improvement.
Yeah, and I think I don't want us to be complacent with above the national average. I didn't even get the above. I think that we owe our population better service. And I think the one thing that I want to say is it's not consistent across doctors' surgeries. If you go anywhere where there's a multi people talking, they often are talking about the fact, if you listen to conversations, how that they managed to see their doctor last Tuesday and somebody else, oh, I can't see mine for 6 months. And, you know, I'll be dead by then. And what I'm saying is that there's this inconsistency of people's conversation. And what we need to do is bring the service for every doctor's surgery to be working to the same service. So that doesn't matter where you live, rural, urban, doesn't matter where you live, you get the same service. And that's what we want to aim for.
I couldn't agree more. That's where we want to get to. And when I spoke about the GP support unit earlier on, that is the ethos and the sharing of best practice to get us to that same place where everybody across the county has equal access to.
Thank you very much.
Services.
Okay, well, you've had
I'd like to also echo that and just to reassure members as well, that we do have primary care localities within our team that are embedded in each area. So Luke and I are two of those, and I actually sit in my practices so that I'm there to answer any questions and problem solve. So I cover Sedgemoor. So thanks for Bruce. If you need to chat, we can definitely do that. But our aim is always to be the best, and my primary care networks know that I like to be at the top, and I do challenge them to be the best. And we have seen considerable achievement for that, particularly in Bridgewater, actually. And I know that Luke is very competitive with me on that. So between us, we are trying to drag those standards up, but our aim is to always be better than the national average and to be right at the top and to get that consistent service. But it does take time. So we will work with you and with members and with our patients to get there.
That's really good. We would like you back in October. Is that okay? Come back with, is that going to be acceptable?
I will definitely be there, bring back however.
And this team is very good. This team's been very good today. You've taken a bit of a grilling. And I'd like to thank Sam. You've been very good answering, and Luke, especially to Kina, very good today. But you will be expecting another grilling. Is that okay? Because that's what we
We can
do.
share the data set.
Yeah.
We can share the data set information with Helen.
Thank you. If you work with Helen on that, and then we're working on every bit of information, if you go through Helen, that we can distribute to all the committee, anything you want in between. I think leave it till October, but if you did feel there was something,
And I just recall, Councillor Oakes was talking about something to do with stroke, but I can pick that up with Helen as well.
we'll do that, yeah. So thank you very much for coming today. And we were gonna have a break in a minute, next one, but I think I'm gonna give everybody a 10-minute break now, if that's okay. Because, thank you so much for coming. Thank you. Having us.
Thank you.
I'm getting a bit short. Okay. Thank you, members. Thank you. We're now on item 7, which is the Somerset Adult Social Care, the CQC Local Authority Assurance Outcome, which is on pages 29 to 64, I apologise. And before I invite David Coleman Groom, Executive Director of Adults and Health, who's online, just wanted to ask Sarah Wakefield if she wished to introduce.
Yes, thank you, Chair. We did mention it briefly yesterday at executive, but I also deferred the fact that we are having a proper discussion about it today. It would be fair to say that I'm extremely disappointed with the result we got from the CQC. To put it in context, it's a new process, and we were inspected towards the end of the 2-year period for inspecting all the authorities who do this kind of work, who do adult work. It didn't work in our submission to what the CQC were looking for, as well as some other authorities did. That isn't an excuse. I'm simply saying that we didn't evidence the outcomes of our strategies for reducing wasting, or our fair distribution of resources, and we didn't incorporate lived experience enough. What we did show was how proud we are of our staff and our VCFSE in Somerset and the support it gives us, our market management of our care sources, and our SILTs and our enablement offer. But the CQC were looking for something different. They wanted a different emphasis, more assurance about social impact across the board. So I think we could have focused our report slightly differently. But we did, as I say, show how proud we are. And I think the plaudits they gave to our staff for the things we're doing well were good. But when you want to get a good mark from the CQC, you have to work for what they ask you to do. And I think we missed the target rather. I think we could have done better. I'm not sure we would have even got good, but we could have done better than we actually did do. So we're obviously looking at that, but David will explain what we're going to have to do next as a result of the requires improvement mark that we got. But I do want to emphasise that, yes, of course, I am disappointed for the team and for all of our staff who we know work extremely hard.
Thank you, Councillor Wakefield. Thank you. I think we were all disappointed as well, like you, that we were not informed. And I think the informative of this was disappointing as well. So I think that's something, but I'd like to now go to David Coleman-Groom, who's online, who's going to present for us. Welcome.
Hello, thank you, and thank you, everybody. So apologies for not being there in person, and actually just to say that Emily is because she kindly agreed, because she's in the room, she'll take you through the presentation and talk it through. But I just wanted to say a huge thank you to everybody that was involved through the process. It was a long process in terms of getting up to the CQC visit on site. The staff did a great job in preparing for what they thought what CQC were asking for, but there's definitely been some learning for us as a department, and we've met with the staff, particularly the management team, and we're going to go out and speak to the frontline staff as well in terms of how can we do things slightly differently in terms of it. But this, as Councillor Wakefield was saying, this was the first time that adult social care has been inspected. I think it's about at least 14 years. So there was a change in legislation that meant that social care would now become inspected. So this was so for some of our staff, it was the very first time of ever experiencing any form of inspection. So there's a lot of work that's already happened. The team haven't waited for the CQC report to come out. We have done a lot of work. The team's done a lot of work since September, and I'd just like to apologise if people feel that they weren't kept informed and things. The time that we were notified in terms of the report was finalised and was published was literally a matter of a number of days, and we were clearly told by CQC it was embargoed and was not to be shared anywhere. So we had to keep that really, really tight. Staff didn't hear about it until literally the day before, and that's because the media were allowed that they could start publishing it or talking about it from midnight on Friday, though the report was not going to be published and available until at least 10 o'clock on the Friday. So there's a lot of learning for us, but also a lot of learning for CQC to make sure that things aren't leaked out and to move through. So if that's okay, I'll hand over to Emily to talk us through the kind of the strengths and the areas that we want to focus on.
Thanks, Phil. So just a high level presentation to go through, and as both David and Sarah have mentioned, we are very disappointed in terms of the result that has come through. David's covered the role of CQC, and we've talked about this in the past. This is, as we've said, this is a new approach for local adult social care and local authorities across England. Just a bit of a reminder in terms of the assessment journey that we went on. So we received our first notification from CQC that we were going to be inspected on the 7th of April 2025. And as part of that notification, they asked for what's called an information return and our self-assessment. So there's various data that was shared with the CQC. That was done on the 2nd of May. We then had to submit a number of cases, identified cases under different cohorts in different regions. That was submitted to the CQC on the 19th of August. We then had an introductory online presentation with the CQC that was completed on the 2nd of September. Thank you to those that were involved in that presentation. And then we had our on-site visit that took place between the 23rd and 25th of September. Our lead assessor unfortunately had an accident which involved, I think she fractured her collarbone, so that delayed our draft assessment coming to us. So we didn't receive our draft report until the 14th of February. We submitted a number of factual accuracies back to CQC. And we just supplied additional information back to CQC back in April. And then the final report was published, as you're aware, on the 5th of June. But just as a reminder, there are 4 themes that are covered within the CQC assurance process. So theme 1 is about how local authorities work with people, including unpaid carers. Theme 2 is about providing support. Theme 3 is about ensuring safety within the system. And theme 4 is about leadership. Under each of those themes, there are 2 to 3 different further subtitles as well. And that's the way in which CQC build their assessment framework. This grid shows in terms of a summary of the scoring, and it covers across all the 9 different domains under the 4 themes, and also shows how they calculate that. So they look at people's experience, so they talk to individuals, feedback from staff and leaders. They look at our processes as well, feedback from our partners, and then they come up with the overall and overarching scoring, and that has led to the score that we received, and that falls in the bracket of requires improvements. Let's just go through some of the key strengths for now. So and what was identified within the reports, and what CQC said about Somerset was that the leadership and culture and workforce was positive. There was visible and approachable leadership, which improved stability and openness. Staff felt well supported, have regular contact with leaders, and value the learning and development opportunities and career pathways. They recognise the successful international recruitment, which has supported in reducing vacancies and supporting our teams. That keeps frozen. Stop sharing it.
It's all in the papers anyway. So worst case scenario, you can see it on our screen.
We can see it on our screens. So
Okay, I'll stop sharing.
Something very wrong happened there, isn't it? Why?
So looking at partnership working, now this was our strongest theme across the whole assessment. And what the CQC assurance recognised is those positive relationships across with our system partners. So strong examples of collaboration that can be seen. Examples were given surrounding our integration with our mental health service, so with our open mental health colleagues, joint commissioning and governance structures, multi-disciplinary working at a neighbourhood level, and our voluntary sector and community engagement is well embedded, particularly surrounding our village agents and our talking cafes. And partnership working was already showing improved outcomes for individuals, and some of that was noted within our hospital discharge processes. Preventative and community-based approaches, so a really strong offer, especially surrounding our village agents and community hubs. They recognise the investment in prevention and independence that is being a strategic priority. Our Somerset Independent Living Centres, where supporting people with surrounding equipment and adaptations, enabling more people to live at home. And looking at our reablement improvements, particularly surrounding our pathway 1, people discharged from hospitals, we've increased that access and been able to improve service. Our market and commissioning, including the use of direct payments, so they recognise good market capacity overall, a strong micro provider provision across Somerset, particularly in some of our rural areas, and the support for self-funders and our direct payments as well. Governance, data and improvement infrastructure. So they've been recognised as significant improvement in our data visibility and our performance dashboards as well. Our clear governance structures and risk oversight was improving. Our strong audit framework and practice quality processes are in place but needed further time to embed. And that culture of learning and external challenge was also recognised. Moving on to areas of improvements, our waiting times, and we've talked about waiting times within this committee before, surrounding our Care Act assessments and reviews is a significant issue for us. And we have got waiting at the time of assessment, at the time of the assurance visit, there was significant wait times for assessments and reviews. They also highlighted our backlog. Is quite a significant challenge for us. Inconsistency in quality of practice. So they felt that some of our assessments were deficit-based and were not necessarily co-produced or strength-based. And the feedback that they had from some carers was that there was a feeling that people had to fit into services rather than services being shaped around them. Our practice quality frameworks are there, and we've got good governance arrangements surrounding that, but there is inconsistency in terms of the impact that was having. Mentioned carers already, but carers feeling that not consistently identified or supported. So areas of good practice, but that wasn't consistent across all areas. Sometimes there seemed to be a lack of awareness of entitlement to assessment, and there was some long waits for carers assessments, and looking at limited contingency planning, particularly surrounding some respite opportunities. Another area that they identified was about our quality and understanding of need. So they identified that system-wide understanding who is accessing services. And that's sort of strategic approach to inequalities. We had they felt we had limited data on seldom heard groups at the community level. And some of the engagement with some of those groups seemed to be more ad hoc than systematic. Outcomes. What they felt that there was a lot of activity that was taking place, lots of work that was being completed, but it was our ability to really evidence those improvements and impact into outcomes for people. So that impact of prevention. So whilst we've got brilliant recognition that our preventative solutions are there, what actually is the outcome and how are you measuring some of that? They felt was lacking. So, in terms of safeguarding, they recognised or felt that our decision making, particularly surrounding the recording at the front door, was inconsistent. They felt that when we were undertaking Section 42 inquiries for a safeguarding, that was person-centred and met the safeguarding personal outcomes, but were concerns surrounding the front door decision making. Co-production was another area. So co-production, they recognised was in place, but again, wasn't consistently embedded throughout our services. And people often felt that they could find information referencing some of the changes in terms of through our website, some translation documents being in some translation accessibility formats as well. Some of the next steps that we have undertaken already. So David needed, post publication, David needed to submit back to PwC his reflections. So that has been completed. And what we now also need to be doing is an improvement plan within 3 months that will be sent to the Department of Health and Social Care. And we will have to provide updates and monitoring review of our improvement. Some of the immediate steps that have been taken, and as David has already alluded to, none of this waited until the report was published. We've already been making some significant improvements across the operational service and within commissioning as well. We have now got service directors, so both myself and Paul Coles are overseeing 2 of the 4 areas. So I am overseeing theme 1 and theme 3. And Paul Coles is overseeing theme 2 and theme 4. We have an SRO lead for each of the 9 areas, so a senior responsible officer, so either a head of service or strategic manager that is responsible for one of the 9 different domains. We have a performance oversight group that I chair on a Tuesday, that's been in place for some months now, that is monitoring and tracking our performance across our assessments and reviews across our operational service. On the 17th of June, we held a managers session to go through the report once it was published and to for our managers to contribute to the improvement plan. We have a Directorate Governance Review underway, and we've got our CQC Assurance Directorate Leadership Team monthly meetings that are also in place. Within the slide deck, it does talk about the next steps for CQC. They're still finalising some of the arrangements that is going to be taking place to how they will be undertaking some of those assessments moving forward. We do know is those local authorities that have scored requires improvements. We know of one other local authority in the southwest area that again scored a requires improvement. It was 2 years to the day that they had people visiting. They are now going to be going back in. So we believe we have around about 14 months before CQC are back in to see us. So we need to make noticeable changes to ensure that we receive at least a good. So I'm not intending to go through the forward in terms of CQC. I'm very happy to take any questions.
Thank you very much for that, Emily. Thank you. It's very good. And Councillor Quiche.
Yeah, thank you to Bill Minister. It's just a comment, really. I'm a trustee of a charitable care home who was subject to a CQC report, I think it was last year. And we met as a committee and said, well, that does not reflect at all what actually happens in our home. So we challenged a lot of it. So all I want to say is what we struggled with, and I think you said something, Emily, at the start, what we actually struggled with was the change in emphasis halfway through the report, halfway through them doing the inspection. So the things that we prepared for, they didn't want to look at. And it was that records are important. But I just wanted to make that point because I think the CQC come in, and as you say, you've now got to wait 14 months for them to come back. I mean, do they take into account the lack of funding for adult social care? Or the Casey report that's due in, 10 years' time or whatever it is? And I don't think they take into account all of those things. So when I saw the results of the report, at first I thought, oh, goodness me, that's terrible. But I actually don't think it is. And listening to you and what you're going through, I think we have to be mindful of they do these reports, how they come up with the decisions they come up with. But it's just a comment. It's not a question. It's just a comment from me.
Can I put
Yes,
that?
please.
Thank you for that. I mean, I think that it's very difficult for them to do any sort of assurance in a very time limited way. They spoke to a small number of our workforce. They had various different drop-in sessions. They spoke to various leaders, but essentially they were with us for 2.5 days. However, we do need to recognise, and there are some areas that we absolutely need to improve on. So we need to acknowledge that as well. There are some really key strengths in here as well, and as you all know, worked tremendously hard, and we're very, very proud when they came out of those sessions with CQC. They felt that they had represented themselves and Somerset Council in a really good way. So whilst it's very difficult for me as a leader, it's very difficult for our workforce as well. What we need to be able to do is use this as a springboard now to improve is what we need to do, and would welcome the opportunity for the support of this committee to be able to hold us to account as well and to challenge us and make sure that we've got our improvement plan in the right place and where we need to get to. But yeah, thank you for that.
Thank you very much, Annie. Thank you. Can I go to Councillor Power, please?
Thank you. Thank you very much for the report. Came through. I completely understand how it's really difficult at the moment, and when you have inspections, I mean, I've had inspections for work, they come in for 2 days, but then, it's just a tiny view on a wide scale of what actually goes on in the workplace, and sometimes they most likely come in when you're short-staffed for those 2 days, so it's not a reflection on you guys at all. I just wanted to touch on for let's say the vision going forward over the next 12 months of what are the challenges you really want to target of changing. So let's say in 12 months time, we can go, oh, we've achieved that, and we've achieved that. Regarding the safeguarding part of it, which was one of the things that stood out for me personally, and actually was one of my residents as well, because we've had a couple of questions was asked when they've seen the report that went out through the media. They just wanted to ask, so what assurance can you give to us as a committee, and obviously to the wider residents of Somerset, that what assurance can you give that adults at risk, the ones that are at risk, are safe whilst the improvements are being made over the next 12 to 14 months? Thank you.
Thank you very much. Yes. Safeguarding in particular, we have made changes already to the front door, so that we've addressed the concerns. We'd already done that. We'd already started to do that before CQC had come in, but we weren't able to demonstrate the effectiveness or the sustainability of that because they were very recent changes. Some of that has been monitored by our Safeguarding Adult Board as well, and our independent chair of the Safeguarding Adult Board, Professor Michael Preston-Shoots. So we submit our reports through to them as well. We're working in collaboration with our partners as well surrounding this. And then we've taken it to another level where we are going to be looking to redesign some of that as well. We've got a more robust audit process that is in place. So we are, that was some of the concerns that they had raised through was actually how are we making sure the decision making is robust and appropriate. We've then also got, there was also something in the report about how do people know as to how we contact some people back. All of that has been addressed. So we've addressed all of those main concerns. What we do recognise and what the report recognises is that when you get to a Section 42 inquiry, actually that practice is really strong, and that's what people should feel safe about in terms of that. All of our data is monitored and tracked through, as I say, through our performance reports, so through the safeguarding adult laws. So there are various other governance levels looking at that as well.
So just come back, sorry, just really quickly.
Yes, sure.
Yeah, thank you, Fran. I can really understand the points that you've just raised forward, but with the residents out there that have seen the report and through the media, it's making sure that we can push through that positive message that what we are addressing going forward, so that, you know, we don't get seen as a bad name because it's just one report that they've just been in with us for 2 days. You see what I mean? Thank you.
Yeah, absolutely. And we're working on our comms plan as well, so that we are we're going out to the public with some very strong messages and relating it back to our CQC report. So we've done this, and that relates to this part of the CQC report where we've improved. So we're relating it back. And so we have got, as part of our improvement plan, that will also be fully communicated, not just in committees such as this, in the other various committees that both David and Sarah are also attending, but how are we utilising our social media to get out there as well, and keeping members updated in terms of the improvement activity and the changes that we've already done, so people can also be talking to residents and communities as well.
Police officers get subject to this sort of harassment. I mean, you'd think that if there was one group of women who this wouldn't happen to because they've got the
Apologies for the delay. Can you hear me at home? Please let me know if you can.
We can hear you. Yes, we can hear you.
Welcome back. Welcome back.
So at the moment, the microphone's going to go through your laptop. It's working temporarily. So I'll say just leave it as is to get through the meeting.
Okay.
And then after that, it's working. So we'll see what we do after that.
Okay, so don't touch anything, that should be fine.
Yeah, just leave nothing.
Thank you very much.
Okay. That's nothing, Jill.
So is it your computer now that's entirely holding this thing together?
Right then, we know back on track, and welcome back to members online. Apologies about that little technical error. We're going to go back to Councillor Bailey, who was talking about obviously the CQC report. And you'd like to start that paragraph again, that would be great.
Thank you, Chair. Yes, yeah, for those of you who missed my nuggets, I'm really saying thanks for the current work that's going on, being honest about the CQC reports. I wanted to make 3 points. Firstly, to applaud what was going on successfully at the moment and to make sure we hold on to that. Second one was to ask a question about how we're going to train ourselves to answer the question next time when the CQC come around, what practices we're putting to make sure that happens without distracting from fundamental work we all do anyway. And the third thing was really about how you will report back to this scrutiny committee. Shouldn't be really sort of out no detail, but maybe a RAG report or whatever system you've got already going. I'm not asking for an additional one. I think that's going to be ridiculous to do that, but to have something which would give us an idea of each of the areas and where they're performing. And that was my third question. Thank you.
Yeah, perfect. We are intending to bring our improvement plan to the scrutiny committee. I think we've got it scheduled in for October, and then we will bring regular updates. I would agree with you, Councillor Bailey. We will use the same performance dashboards that we will be submitting in various other devices as well. There'll be a covering report as well, but yeah, regular updates will come to this scrutiny committee. Really important that this scrutiny committee is involved in that. As for the learning, we have learned a great deal already since September. Learned from others, other local authorities up and down the country as well, and in terms of how to position ourselves. So I think we will be better informed next time when they come back to see us.
Thank you.
Thank you, Councillor Bailey. We were going to actually at the end of the meeting say that we were going to organise regular updates, and obviously the team are coming back in October, which is actually on the plan. But thank you for that, Councillor Oakes.
Thank you, Chair. Graham Oakes, Yoverleys. It's an interesting report. I have to say, not as a user, but as someone who interacts with that part of the council on a regular basis, I'm surprised. I thought that you would get a good, I didn't think you would get an outstanding, but I thought you would get a good. But then again, I think I fell into the error that people make. This is a CQC assessment. It's not a test of the quality of the service. Those are entirely different things. If it was done on priorities, you would get a good. But it isn't. It's done on the fact that you have to tick every box. And I'll give you one example. In this report, it points out that you weren't very good with dolls. No authority that I'm aware of is good at dolls. And there's a reason for that. Because of the Cheshire West judgment, literally hundreds and hundreds of people had dolls applications that aren't and weren't needed. And I can now say that because the Supreme Court agrees with me and all the other people involved, I think, that it's one of those things. The other area of failure is the ability for you to do reviews of people who are content. The services function is always going to lean towards people who need them rather than people who want them. And consistently, Somerset provides an excellent service, outstanding service in the areas that matter. If this report contained, and I may have missed it with respect to the lead member, but if this report contained elements that gave me real concern, I would be expressing them. But I just feel sympathy for you that you came across CQC who were not fit for purpose, who are seeking to improve, but have got a new process and still haven't reached the point where they actually review in a way that would actually benefit those of us at the other end, all service users. I don't think this report actually does that. I think it highlights some areas of weakness, but if I had to choose areas of weakness, I'm glad it's those. And I don't think it's fair and balanced. I don't think it really sums up what goes on. That's my opinion of the service. And like I say, I'd always give you an honest view. And I think that most of the ones who have regular interactions would say Somerset is one of the better South West County. You're mean with your fees, but apart from that, you far outperform Dorset, for example. Far better council in that way. So I hope that the staff, I know the leadership will take a kicking because that goes with it, but I really hope that those frontline staff are not affected by this, that it's not a question of what they do because they consistently, the vast majority of them consistently perform to a very high standard and we need them to do that. So I just hope they are getting the correct message rather than the headlines from CQC. Not a question.
Okay, so just quickly, just about Declaration of Liberty, which is what Graham was referring to, just for those who didn't know what it meant. If you are in a place, safety, I suppose, a care home, and if you are being held there, in other words, you're not free to leave, the Deprivation of Liberty legislation comes into play, and you're supposed to be reviewed, I think, once a year, probably, but we concentrate on people in that situation whose deputy or whoever's looking after them or their personal spokesperson or themselves are saying, I want to go home. I don't want to be here. So you're concentrating on the people who are not happy because you don't want to restrict people, but some people need to be kept safe from themselves, from the public, whatever. They're not criminals, but they need to be kept somewhere safe. So the fact that we have a backlog of reviews, as Graham said, isn't the most worrying thing for me. It just isn't. It would be great if we had enough people to do all the reviews, but actually we concentrate on the other reviews that you have to do and the other things you have to do, the Care Act assessments and so forth. So we have got a backlog, but it's not dangerous. It's because people in that situation need to be looked at, and of course they do. And sometimes when they're looked at, the way we look after them changes. But if they're not kicking up against it and packing a bag every day and saying, I want to go home, then we tend not to do it or put it at the top of the list.
Thank you for that explanation, Sarah. Thank you. I think the thing that I was impressed with as well is, and then you've got it on your, is obviously the assessment going forward and the fact that there will be senior level meetings. There will be meetings will be agreed 2 months in advance and we'll be a little bit more on the ball. I think the major risk is a big issue, And I think we'll always know that long waits for assessments and reviews remain that major issue. And that's something we can work on. But I think we are where we are. And I think what we have to do now is thank you for letting us know the positives, because that's not as dark and it's not as deep as not as dark as I thought it was going to be. But I think there are the improvements that you've already addressed. And I think that's the good thing about anything. When there's a mistakes made or something's picked up that's not running well, you actually know where to find them and address them. And that I thank you for very, very much. Thank you very much. So thank you for the report. Thank you for the work it's doing. And I would just say to all the staff, we need to go up forward and we'll make it better next time. But we do want to see you regularly. We do want to have updates from you. We don't want to be caught on the hop like this. Nobody does. But the next time, I foretell this is going to be much better. So thank you very much. Thank you. Okay, the next item on the agenda is the Somerset Tenant Strategy 2026, pages 65 to 170. And I'm inviting Jan Errington, Strategy Lead Adults Care Commissioning, to present this report. Am I correct? No, I think it's, I'm sorry, this is not Jan, this is Kirsty Larkins. And I pass over to you, Kirsty. Sorry, apologies.
Yeah, I'm just going to give a very short.
Sorry.
This tenancy strategy is a really important thing for the council. You have to have one by law anyway. We have got one and it's being updated. One of the reasons it needs updating at the moment is because we've got new legislation, but also because the old strategy dated back to 2012. So it's been around for quite some time. So this is a good time to do the update because we've had new legislation which we need to incorporate. It's going to be more in keeping with our council and corporate plans and our vision as well. And it has more emphasis on prevention, which is referred to in the National Plan to End Homelessness, which has also recently come before. So it's got some good things about it. We should be proud of it. And we're presenting it to you so you can ask us questions about how it's going to work. And I'll over to Kirsty.
Thank you, Councillor Wakefield. I have got a whistle-stop tour for you because I'm aware there is a packed agenda today. So Councillor Wakefield's already covered that this is a legal requirement of us as a council to have. It's a high-level approach, providing a framework for social housing providers and aims to contribute towards housing stability, affordability, prevention of homelessness, through fair access and tenancy sustainment. It also supports, as Councillor Wakefield's mentioned, homeless prevention. Jan has led the work on this, Jan Errington, and has done that in collaboration and consultation with social housing providers, other professional stakeholders, and also tenants associations. And it will be reviewed in 5 years' time or sooner if there's a substantial change to the legislation. There's some key elements. I'm not going to read through the slides, and this is in the report pack. And there's some key principles that have been threaded through this that all of our partners are asked to work to. Probably worth saying that whilst this is a legal requirement of the council, our partners do not have to adhere to it. There is no kind of teeth to the document. So whilst it is a legal requirement and framework, there isn't any kind of legal requirement, although I think most agree with the principles and will work in ethos with those principles, which I think is very positive for Somerset residents. So there's 3 recommendations: consider and comment on the proposed draft, recommend the adoption of this strategy to the executive, and also recommend to executive to delegate authority to exec director for adult services and housing to approve any changes in consultation with the service director for housing, which may be required due to further legislative or central policy or central government policy changes. Thank you, Chair.
Thank you very much, Kirsty. Thank you. It's a very big document, I have to say, very big document, and took a lot of reading. And the one thing I wanted to ask before I post to members, you've got the amber and green and the amber, the negative, neutral and positive, but I didn't see any things in that. Is that just because it's in the draft state? There was no identification
Was that in the equalities impact assessment?
In the,
Yeah.
sorry, I'm just gonna just have a look a minute, sorry. Just, it didn't actually tell me, well, yes, I suppose it is. It just didn't say any of that bit of the report, and I just felt that maybe I'd like to have understood why those tram lines were there, if they're not gonna be, it's on page 125, 124 it starts.
Let me just find that page, yeah.
I don't know if anything's wrong with your copy, but every part of the impact assessment is scored.
Yes, and I can see that if you look at the page 124, at the bottom where those tram lines started, and I appreciate it's probably not as clear as it could be, but this is the template. The positive is marked with a cross, but that the commentary under age is quite long. Hence why there isn't another cross until the bottom of 100, page 129 for disability, which again is crossed as positive. I think it may be there's quite a lot of detail because it's a far-reaching strategy. There is quite a lot of detail under the equalities impact assessment.
Oh, I see. So I apologise. It looks just like tram lines to me with nothing, mine have got nothing in at all online. Sorry. So I couldn't quite see if this was where we were with it. That's what I was trying to say.
It's fully signed off and completed.
Yeah.
All of them are.
I think I mentioned this before though, when we were signing it off. I just think I mentioned it, but if that's how it is, then that's how it is.
It's just, and it's a very, very comprehensive equality impact assessment. I have to say the most comprehensive one I've ever had to do, but it's got everything in it. The good thing about it is it's going to help with the next strategy.
Yeah.
And also the one after that. So it's going to be used for more than one purpose. And the equality colleagues were really, really keen to be, because housing is such a fundamental thing, they were keen for it to be as.
So this is like a template, how you're going to run it, and then you're going to be able to fill that in.
Yeah, I'll have to adjust for the strategies, but it's relevant to the other strategies as well.
Thank you very much for that.
Sorry, worth highlighting, Chair, that there are no negative impacts of this strategy. It's either positive and there are a few neutral impacts.
Okay, I don't know if anyone else felt the same as me, but maybe I'm wrong. Councillor Trimnell.
Thank you, Chair. So we spoke about this a few months ago now, and it was really helpful to have a steer from you. I still cannot understand, though, why it's been a lot of work, an awful lot of work, taking a lot of time, and it's entirely unenforceable. It's just a nice to have, something you have to have on the shelf. And I wonder why we have to have something that people can. Generally, they may well adhere to it, but it's almost optional whether providers do or not. And I find it really frustrating that we're expected to put in so many hours of work on something that people may not even look at because it's not enforceable. And if it's not enforceable, I don't know. I just think, if we have to have a strategy, then because, and the lack of enforceability was down to, according to paragraph 5 on page 69, seemed to be because we have so many different stakeholders and so many different housing providers, and they cross different counties and different areas. Why can't we have a national one that does have to be adhered to and do all the work once? All the local authorities.
I think you would then miss out on that local context, which is why there isn't a national one. I appreciate what you're saying, Councillor Trimnell. It is work, but it has been done with partners. So I think, the majority will work with the ethos of this and they believe that is a positive thing. It's government that set a legislation. It's not something that we've set at Somerset Council. It is a national, all councils are required to have one. But the reason it's not national is we miss out then on some of the local elements. What we need in a rural county might be quite different to what's needed in, a large urban area.
I think Kirsty's right. There is definitely buy-in, and part of the reason that modern tenancy strategy has gone down the route of just highlighting good practice and being that overarching framework of good practice is to encourage and push our registered providers of social housing to
adopt the best practice that they can, that they're still businesses in their own right, so we can't enforce it. Having said that, an awful lot of what's in the strategy is encouraged by the regulator of social housing, and the new legislation that's coming in, the Renters' Right Act legislation, which isn't in force yet for social housing, and we're just waiting for a new direction on tenure. That's going to really dictate the types of tenure that private registered providers, not councils much, can use. It's going to affect then consumer standards that are referred to in the strategy and the report, which will be updated, and it will be much more about using tenure for the right outcomes, for the right needs, and in a sense, the strategy is already kind of meeting that future requirement. The other thing that I've tried to do with it is tie it into the homelessness strategy or tie it into the housing strategy and link it so that we then end up with a suite of housing related strategies that are all about supporting the health and well-being of our residents in Somerset and improving the system overall. So they should all join up together. So even though I haven't got any teeth as such, I still think that in that system of strategies, it kind of underpins the whole direction of travel for the council. So I know what you mean. It is a bit frustrating, but that's why some of it's phrased as we would encourage our partners to do all of the things. But a lot of them already do quite a lot of the things. I don't want to say all of them, but it's not like they're starting from a blank sheet of paper. Some of them will have very good practice in place already.
If I can just certainly very quickly, I mean, it's a really thorough piece of work, and I know how hard you worked on it, and I know how much is involved and how much is included in it. It's just well done for putting this together, knowing that people can take or leave elements of it, and having that faith that people will. I think that's really important. That providers will pay attention and will try to abide by it.
I suppose it's sort of like a Bible, isn't it, really? I suppose it's a referral, isn't it? You look at it and then I mean, I love the glossary. I'm always a great believer in glossaries. At the end, I think that's good. I think because people do forget what certain, functionality terms are. I think that's excellent as well. So thank you for adding that. That's a very small minor bit to the very, very in-depth. Slightly repetitive in some areas, but I guess it has to be. I felt like I was reading the same thing over again at certain times, but I suppose it has to be, you're saying the same modelling, I suppose, that's why, isn't it? But no, is there anybody else would like to add anything to this? Okay, the recommendations are to consider, and we've considered it, recommend, subject to any amendments, we don't think we have any. The adoption of the Somerset strategy by the Somerset Council, recommend to executive to delegate authority to executive director, adult service and housing to approve any changes in consultation with the service director, housing which may be required to further any legislative or central government policy changes. I hope there isn't any changes after you've done so much, I'm going to be honest. But are we all in agreement in that? Yeah. Could you just show our hands? Right, thank you very much. And it's extremely, this must have taken some time and it has to be done. I get it, but thank you very much.
Thank you.
Okay, my members, item 9 is Somerset Health Determinants Research Collaboration. It's pages 171 to 252. Now then, the invitation I have here is the same. Is Brittany Strange Health Determinants Research Collaboration Programme. Brittany, thank you. I couldn't see you, I was getting worried. So if you'd like to present, please, James. Oh, yes, and Evie as well, please. Sorry. How could
That's okay, I'm so quiet, you didn't even know.
I apologise, Evie, I do apologise. You're always so quiet.
Okay, I'd like to introduce the next item on the agenda, the Somerset Health Determinants Research Collaboration, or HDRC. The HDRC is a 5-year research programme or partnership programme between Somerset Council, the University of the West of England and Spark Somerset. The programme aims to build research and evaluation capacity and capability with the council officers and the voluntary community faith and social enterprise partners. This is done in order to tackle social factors that have the biggest impact on people's life outcomes, which lead to unfair differences within our communities. As we approach halfway point in this programme, this paper sets out how to strengthen Somerset Council's role within the partnership. As you're aware, this item is brought before you today under 3 recommendations, and that's to report annually to you and to ensure that the programme delivers against business plan. We are asking for your continued support and to endorse the research priorities. I will highlight that this programme also aligns with our newly approved council vision. Support from members will ensure that we are proactively working together to build capacity, capability and culture needed to use robust evidence and research to inform our decision-making practices, ensuring that our policies and services generally improve outcomes of residents. And now I shall hand over to Brittany Strange, Programme Manager for the HDRC.
Hi, good afternoon. Thank you. Councillor Butchon has covered it quite comprehensively, so I don't want to go into loads of detail, make it brief. It's just a verbal update and report, and really just asking for your endorsement and support around our recommendations. I'll remind you that our partnership is made up of Somerset Council, Spark Somerset, the University of the West of England, and for 3 years the programme University College London. And like Councillor Potts-Jones was saying, it was supported by Key Decision in 2024. And it took some time. It was a very new program nationally, not just locally. And so it took some time to get up and running. We're at the midway point. And so part of this report is some self-reflection, some assessment of ensuring that we are playing our part as partners and that we make sure that we are accountable to you all and to the public in terms of what we're delivering. And so I'll get straight into the recommendations, which are that we're asking really for the HDRC to report annually, both to Scrutiny and to the executive committees. And that is to ensure that we have some transparency and accountability, that we're delivering against the business plan that we initially submitted to the National Institute for Health and Care Research, and allowing you to ask questions about how we're delivering that program. So asking for your support there. The second recommendation is hopefully you'll be really encouraged to hear that we're already working closely with HR and OD and with Newton on inspiring innovation in that program, because a big part of what we're trying to do within the HDRC is we're trying to influence how the council works. We're here to influence. If I use the word research, it can sound a bit scary and academic, and it's not really about academic research. It's about how we make decisions. It's about being a council in terms of our new culture as we're establishing that and our new identity as a unitary council, to say we are a council that when we make decisions, they are evidence-based, they are driven by the evidence in terms of our policies, our strategies, and our interventions. And so we want to make sure that as Newton and HR and OD are implementing an inspiring innovation program, that we're embedded in that and that the HDRC is a part of shaping that conversation about how we want to work. And so we're asking for your endorsement there. And then finally, the recommendation is that you support our identified research priorities for 2026, which our funder NIHR has asked us to submit for this year. And as Councillor Jones was saying, I hope you'll be encouraged that they are very closely aligned to the newly approved council vision. Those areas of research interest or priority are economic inactivity for working aged adults. Sorry, they're all mouthfuls, it's memorizing them all. And then the second is around housing in place, which I hope Kirsty will be pleased to hear. And then thirdly, we're looking at children and young people, so specifically around 0 to 2 in early attachment, and then 12 plus around educational attainment and belonging. And finally, our fourth is a little bit vague. It might read as vague to you, but it's about emerging community themes, because we don't want to assume council officers or services know everything. Our communities know an awful lot. And so how do we create space and processes for communities to identify what's emerging, specifically around health inequalities or the building blocks of health, that we can link with council officers and start to do work around those topics as well. And so those are our 4 priorities, but I'll hand it back to you, Chair, and to open it for any questions.
Thank you very much. It was an interesting report. I was especially the 12+ school absenteeism and belonging. I think that's very, very important. And I think, you know, of course, anything engaging with children, young people, though we have children and young people scrutiny. I think for us, understanding that and understanding issues, and it's good that somebody's doing some in-depth, because I think we're hearing about that a lot of children not engaging and not joining in, and there must be a reason, and yeah, I find that very interesting. So I think the 4 elements that you've picked up, housing in place, and the emerging research priorities as identified by communities, that's really important, because every community probably has something different to add, don't they? And yeah, I think you've captured that very well, if I may say. So thank you for this. Councillor Lucy Tremble.
Thank you, Chair. So thank you very much for this. So I was opposition lead for public health when Trudy Grant, who is our Director of Public Health at the time, applied for this, and it was a really onerous process, and it was such a coup, such an amazing thing to be able to be part of. So it's very exciting to be able to see it coming to fruition at this stage. I had a couple of points to make. So first one is in terms of the recommendation purpose 3, I thoroughly recommend and endorse the research priorities, particularly that 3rd and 4th relating to children, because there is so much work we need to do with our younger people, because you know, ignore the youth at your peril, I think is the point. Now there was something in paragraph 17 which I vaguely remember, so page 189, uplifts in pay which the council were not allowed to factor into the budget at application stage. Can this be just expanded a little bit more? What does that mean in terms of our budget? I think what I read from it was that the pay was set at a point that was high enough that missed pay uplifts that we weren't allowed to factor in could be allowed. So, and then I've one after that.
You've got an exceptional memory. Yes, that's correct. Yeah, so when we were factoring that in at the beginning, we had to factor in the progression of that period. And what we've also done is we've factored in potentially inflationary increases year on year as part of how we've done the costing. So we had to be clever and build it in. And there are other cushions that we've created to ensure that we can cover full salary and staffing costs through the duration of the program without being in a pinch. Yeah.
That's brilliant, thank you. And then there was just one thing which sounds like a criticism, and it's not. On page 245, so I can't remember what the title of this, the research priority areas year 3, it's sort of, you've got your priority areas, your context and your activities. It was only a point on the layout, basically. So we've got children and young people in the first column, and the first thing was there were no column headings on every page, and so you had to keep going back to remember what that was for. Early attachment, the information there, and then the last comment, in conversation with Open University researchers to support the evaluation of the mother's object relations tool, but actually on the left-hand column, next to that is 12+ school absenteeism and belonging. And I think there might be something with the formatting that could just be changed, because you start to think when you're reading something, well, have we moved on to the next? The columns aren't relating to one another. And I'm sure it's easily fixed by somebody who's infinitely more clever than me. Thank you.
And that's a helpful point. We'll look at formatting. So that was a supplementary report that off of our annual report that NITR asked for, but we can look at that and then check it.
Yeah.
Thank you.
Thanks.
Anyone else? Anyone, other members like to speak? Councillor Power. I'm sure that you wanted something to say, Councillor Power. Oh, you certainly don't want to? Okay, fine. Okay. I just wanted to ask a brief question, if I may. It's about getting it. I was really interested as well. It's about getting people back to work, getting, you know, I mean, that's an onerous task, isn't it? But, you know, you've got the white paper put in here as well. But you know what, the inactivity from working age people, that we've got a tremendous problem, haven't we? And if there is, and I mean, you going to tackle that, or are you just finding the detail about why, or?
Yeah, that's a great question. I wish you all could have been in the room with us on Tuesday, because we had our funders then on Tuesday, NIHR, and they were doing a spring visit. And as a part of that, we invited a lot of our collaborators to be in the space with us, and specifically to talk about some of the economic and activity work that we've been doing. So we've been working really, really closely with Melanie Thomas from Workforce and Skills, who's been heavily involved right from the beginning of the HDRC. And we undertook a study called Breaking Barriers that we'll be looking to hopefully publish in the next year or so. We've got one internally published, but in a peer-reviewed academic journal, we're hoping to actually share some of the learning. It's been a phenomenal piece of work. It's really encouraging. So it is an issue in Somerset, and even though we're not outliers nationally, we have a kind of better than national average employment rate. But when you look at the aging population, if we have people out of employment, there's a bigger impact because of how our population figures swing. But what we've done through that study is we have engaged with community organizations and people with lived experience to shape our approach. And that has been informing the Connect to Work and Get Somerset Working strategies and guidance. And what was really interesting is that we just set out to get that information and include communities in our approach so we can better understand how to ask people specifically with long-term disability and health conditions about their experiences of unemployment or employment generally. And what has since happened is that there have been ripple effects where the community organizations we're working with, it's changed the way they work now. So it's not just about informing the strategy. Because we've approached it in this way, it's actually changing the way community organizations work. And loads of them were sharing how even in community groups that focus on neurodivergence or community groups that work focus on addiction, that they're changing their structure. And they've got people in employment since we've undertook that study that have been long-term unemployed for some time.
That's really good. What I wanted to say, if I can add to that, young people, they would been absenteeism from school with a special a health condition, autism, that don't get statemented. So they're in the middle, they're caught in the net, they leave school without anything, and they're still home. And I've got a few of that in the ward I'm in, that where people are asking me, what is out there for those children? Because they weren't statemented, so they're not, but they didn't go to school as long as they should have done, for many, many reasons. And now they're home, and they're young adults with nothing at all. And the colleges are trying to do their very best. But how do you proceed to work with that? Is that a possibility?
Also love that you've asked that question. So we're specifically, I have a meeting tomorrow with UCL, one of their researchers, because we're doing a briefing paper, which you're nodding because I think you know about, Emily. We're doing a briefing paper in partnership with our education colleagues and other children looked after to focus specifically on a paper that surrounds neurodivergence, school absenteeism, and the impact on families. So looking at those challenges, does school absenteeism lead to increased pressures and potentially children ending up in care with limited opportunities, or is it vice versa, or a bit of both? And so we're hoping later this year to have a briefing paper produced with the UCL that explores that topic specifically.
Really good. I'm sure the committee would welcome you coming back at some point when you think it's pertinent for you to let us know how things are and how you progressed with this. I think it's a very, very interesting subject area all the way through this. So somebody else wants another question, but I want to thank you for this report. It's very, very interesting. Councillor Bruce.
Thank you, Chair. Yeah, thank you for the presentation. I just wanted to ask a question about how it works in practice and give an example of the housing in place priority. We're looking at the supported housing strategy. So this quantitative and qualitative research that's going to be done is going to inform a review of the supported housing strategy. Is that because it was already due for review, or is that just something you've been asked to look at? I'm just not quite sure on how the process works. Thank you.
Yeah, no problem. The order. I'm just whistling. You don't have to come up. If I say anything that isn't quite right, you can come and chime in because we're working together on it. It's very handy. So no, it's not about review. It's about the fact that the supported housing strategy was due. It's due in spring 2027.
It's completely new
legislation expectation.
Jan, why don't you just come on to the table, put the microphone on, and when I hear what you're saying.
And so it's new legislation, and so you approached us early on to ask for our input in helping to shape that strategy. So again, that it would be evidence informed and led in its development. So we've taken a mixed methods approach to look at the data that you have hold of and helping you to create a story. What's the story we're trying to tell around supported housing? But we also are taking a qualitative approach, and I won't get into the detail of that, but it's really interesting. But we've got a research supporter in place who will be helping us to explore supported housing for people with lived experience that will inform this strategy as well. So we're starting at the beginning. Quite often we consult too late. We go in, we can say, here's our strategy, tell us what you think about it. People are informing the strategy as we're forming it instead.
So that is due to be, that strategy should be in place for 2027 we're talking about, are we?
It's got to go to secondly to book it actually by March 27. So it's very, very live at the moment. A lot to do. It's quite complex. It covers all of the cohort with adult social care. It's care leavers and all of their different needs, and young people at risk, and then all of the homelessness cohort. So that would include rough sleepers, complex needs, domestic abuse, drug and alcohol as well. And so it's quite a range of need that we have to project and type with supported housing. Supported housing is everything except residential care and nursing care. But even what we do with rest care and nursing care has an influence on what type of supported and the amount of supported housing we need. So it's part of that overall jigsaw. But this is brand new legislation. It's a brand new strategy. It's never had to have been done before. And there will be additional new regulatory requirements that come in with the Act from 27 onwards. So we will be, or I will be coming back at some stage, definitely by January, to update about the draft strategy itself and also the other elements that connect with it that we need to start implementing going forward.
Interesting, thank you.
Thank you. Perhaps you can both come back in January together, if that would be okay. Because just to let you know that next year, 20 after April, May, committee changes. It's the silly season, and many people that have been interested and want to know what was going on will want to know. So I just want you to just make sure that to put that in your diary, and I know Helen will as well. So thank you. Can I go to Councillor Trimnell, please?
Thank you. It's just a quick one. I think when we were talking about emerging community themes, I think I heard our aging population come up, and that really is a big issue. I'm just thinking more widely, nearly everything that we talk about, particularly on this committee, but actually for the council, revolves around an aging committee. Aging communities. You can tell I'm tired. And what I wondered was, will this piece of work be the information we need, or we need to know more about this? I think we talk about it, but are we looking at how we are in respect to other counties and other areas? We know places like London don't have the same issue with ageing communities, have a lot more younger people. I just wonder whether there's anywhere that there's a piece of work going that's working about that and understanding that in relation to the council and our functions.
I know that Cornwall HDRC is doing, it's not a specific focus on aging communities, but it's, for instance, a study on the use of technology to help alleviate some of the demand and pressure around what they're experiencing in terms of aging communities. So I don't know that any particular HDRC is focused on aging communities. I think what we're trying to do, we know a lot of it in the system within the NHS is focused on that. We know that as the chair pointed out, that young people generally stay in Somerset and begin to age. So we're trying to get to the other end to some degree because we want to be preventative. But I think it's about understanding what we can do in that space. And we're looking for a steer from our funders as well. There's neighbourhood work, and a lot of the neighbourhood work we think probably focus in that direction and on frailty and that sort of thing as well. So it might be that in time that's something we do more on. It's sort of a watch this space area right now. Thank you.
So if there's no more questions, I just want to thank you both for coming today, and again, Jan, for coming back on this one, and Brittany, because it's a very, very interesting subject, and we look forward to seeing you in January, okay? Because really updates on some of the areas we've asked for, that would be really good. So the recommendations are, as you see, Somerset HDRC to report annually to adults. Well, I'm asking for a bit quicker than that, okay? January. So can we report to January? And the executive committee is on research activity and progress to ensure the programme delivers against the business plan. Support for the collaboration between Somerset HDRC and the Inspiring Innovation Programme. The Somerset Council considers how to become a more evidence-informed research active organisation, and to endorse the adoption of the 2026 research priorities. We can only endorse. We're not high enough to do anything else, but we'd like to. Is everybody in agreement, please? Yeah. Can I have a show of hands? Thank you very much. So we totally agree. Wish you the very, very best of luck and keep up the good work. Thank you.
Thank you.
Right, I'm going to go to the next item, and then I will give Councillor Oakes, you're going to leave us.
You have to, I'm afraid.
Oh, with sadness, I say goodbye.
Missing you already, Jake.
Councillor, thank you. Okay. So now I'm going to go to the housing joint asset management, and then after that we'll have a little break, because I realise it's gone on quite long. I'll have a little break after that for just a 5-minute break. So this is, I'm inviting Ian. Ian, I haven't got your name plate. Ian Cavendish.
Candlish, yeah.
Candlish, sorry. Head of HRA Property to present the report. Is there a Naomi? Is she with you?
No, Naomi's not with us.
No.
And she was originally going to go to the exec meeting, so that they see that the feedback from this committee is on the 5th of August. I brought my colleague Dan Bennett along, who's going to time in business now.
Can you put the microphone closer to you slightly?
Yeah, please, they can't hear you at all. And thank you. Well, welcome, Dan. Thank you for coming. Mr. Dan Bennett.
Lovely, thanks, Sarah. The strategy sets out the council's joint objective for asset management with Homes in Somerset. As you'll be aware, 2 organisations are merging their housing landlord functions on the 1st of September. I'm not going to read the whole document out because I'm sure you've enjoyed reading it, but basically this is about spending the right money on the right jobs in the right properties at the right time, so we ensure all our homes are safe, compliant, warm, and above all, desirable places to live whilst being compliant with regulations and standards nationally. Take any questions.
Thank you very much. Sarah, do you have anything you wish to add to that one? That report? No. Yeah.
Not me.
No, well, no, I just thought just in case. Right, does anybody have any questions, please? Councillor Trimmer.
Thank you. I've always got a question. There's always one somewhere. So I wanted to ask about how your spending priorities are going to work going forward in terms of, are you looking at improvements and repairs, or are you looking at upgrading and, things like solar panels and things? Is there a priority? I know there's a trade-off between them, and I just wondered how you're prioritising those at the moment.
Thank you, Councillor Trimble. The strategy covers many things, but the overarching principle is that all of our properties have to meet a minimum national standard for energy efficiency. So we're targeting our expenditure of properties that we can easily bring up to that standard. We can also claim significant amounts of third-party grant from central government. So we're targeting properties that are eligible. There are a small number of properties that will be quite hard to bring up to standard and have abnormally high costs. Those we are potentially disposing of, only small numbers that allow us to continue to invest in the other ones in an economic fashion.
And Kirsty.
Yes.
Sorry.
I was just going to come in and answer the sort of other bit of that question you were saying about kind of how those priorities are set for the HRA. So Eileen setting those priorities overall for the 30-year business plan. The Housing General Fund feed into that and set the priorities. This forms part of the work that's done around those priorities. So things like new buildings, bringing up obviously the condition of stock as Dan has gone through, ensuring tenant satisfaction, etc.
Thank you. So I was just going to come back, and I might have forgotten what I was going to say. I suppose what I'm saying is that we're targeted, like you said, we have a target to meet in terms of those homes standards. And are they safe home standards or standards for efficiency, for example? And then, because we have targets, you said that some of the homes that we can't bring up to those standards, we may need to dispose of. Would they otherwise be perfectly good homes? And how many are we talking about?
Thank you, Councillor Trimnell. So there are multiple standards. So first of all, we have MEES, which is the minimum energy efficiency standards for new lettings and social housing. That dictates that we have to get our properties to EPC level C by 2030. Some of our properties, we can quite easily get to that level through perhaps a solar panel or some improvements to the existing insulation or heating systems. We have a very small number of properties that, regardless of what measures we apply, they will not reach that standard. So those are the ones that we're targeting for disposal.
Just very quickly, so but would they, without this target that's been set, that one could argue is a target rather than a need, and that's not my argument, but would some people be very happy to live in a home that wasn't EPCC for the sake of having a home?
I think they probably would, but the EPCC is national legislation that sets the target, so we can't create new lettings and new tenancies beyond that date of 2030. We've also got additional standards, so decent homes standard, and we have other standards called HHSRS, which look for hazards in homes. So we have to deal with multiple standards and ensure that we comply with all of them.
Thank you.
Thank you very much. Kirsty, sorry, Kirsty.
Sorry, Chair. I just thought it might be helpful to add that Dan and the team work quite closely with our affordable housing team as we try to, with all disposals across any kind of social housing stock, to see if there are funds that we have available to maybe avoid those properties being disposed of, or whether there are other landlords that have a greater mass of stock in an area that makes it more affordable to then bring up to standard. But sometimes, unfortunately, that isn't possible. This isn't just an HRA policy, this is a policy across all of our providers.
One of the areas where oh, sorry, carry on.
Yeah, sorry, thank you. I was just going to add to Dan's remarks that you mentioned about the regulation as well. So we're highly regulated by the regulator of social housing, so they have a whole set of consumer standards as well. So they're picking up on all of those issues, particularly focus on property safety as well as energy efficiency that you mentioned. So yeah, there are a lot of standards that we do have to adhere to.
You probably answered my question. Oh, sorry, you can probably answer my question. I'm very interested and always have been about the national space standards. We have very, I'm talking parochial now, sorry, because I don't know everywhere, but I've been into some very tiny homes where families have nowhere, just one room downstairs, and then say 2 rooms upstairs, nowhere for children, the kitchen and the lounge and everything is all together. And the national space standards says that we need to improve on that. How do we do that? How do we try to help already older housing? Is there any way that we can do that, or is it something that we can't do?
I'll take that question. Thanks, Chair. So the space standards are not applicable retrospectively. So the minimum space standards are something councils can opt into during the planning permission process for new developments. And I believe that the Legacy Sedgemoor Council and the Legacy Taunton Dean Council both opted out of those space standards. So some of the new homes that I've looked at, so nothing to do with the HRA, but new developments in the area, they have remarkably small homes for modern living. But I appreciate some of our homes were probably built at a time where people had less less material goods, less furniture, so they can be quite tight. But I think most of them, I'm pretty happy that they meet the need of the occupancy they're designed for. But obviously families have more children and they grow and the house can't grow with them. So that's when we have to do our duty through the housing team to rehouse people appropriately.
We did put it on our Sedgemoor, was on Sedgemoor, we did put national space standards, minimum space standards, because I nagged to death about that one. So I was on the planning part, we did that. So Kirsty.
I thought it might be helpful again to emphasise our affordable housing team in making sure that any new affordable housing does meet those minimum space standards. So we sometimes have developers come forward looking at rooms that would be smaller. So it might be a 3-bedroom house, but they say it's only fit for 4 people. We would be looking for bigger rooms than that so that they are better homes. So that's part of their team, but that's obviously the social affordable side of housing. We don't influence obviously all housing stock.
But we are trying to, and that's, I think, something we must legislate for. Councillor Bain.
Thank you, Chair. Yes, it was a question that Councillor Trimble raised about the number of disposals,
Oh, yeah, sorry.
which I don't think we had an answer for, and the sort of percentage of the stock would be interesting to know. Thank you.
Okay, thank you, Councillor Bailey. Our disposals are governed by our medium-term business plan. So over the next 5 years, we have built into the business plan an annual capital receipt of £1.225 million, which roughly equates to 7 homes a year over the period of the business plan. When I started this role, I inherited quite a few empty properties that were earmarked for disposal. We did a little exercise around them, and quite a lot of them were in the same ward. So we actually took 2 of them out of the disposal programme and refurbished them because we felt it affected that council ward or division unduly. It was a particularly rural division as well, and we felt that having a number in the same rural division probably wasn't the right decision.
Are there any more questions? Yeah, I don't want to leave anyone out. So obviously, the recommendations are to support to approve the joint asset management strategy 26 to 31, endorse the governance and insurance arrangements within the strategy. Note that a formal review will be undertaken in 2029 to reflect regularity, financial and organisational change. Why so long?
But it's an overall strategy that's for a longer period, but obviously that review that, take your feedback on that. You want to do an interim review on that, but it's a long-term strategy rather than a short-term operational policy. So happy to take that on board though.
I don't know what everyone else feels. I just feel that's too long, 29. But Kirsty, I'll take a guidance by you.
It sounded long, but then I registered as Councillor Wakefield's just said, it is actually only 3 years. And normally when we're looking at a strategy, it would be kind of a 5-year strategy. So I think I'm sure HRA will review throughout the process the impact that it's having on overall stock. But I would suggest, because it is a longer term piece of work, that is a reasonable time frame to review.
Just to add one final point, which is the organisation that the strategy relates to doesn't go live until the 1st of September. So there will be a period of bedding in, restructuring, reorganising, and I think the 2029 days is appropriate.
Okay. It's only because I'm older, it feels a long time to me, but it's okay, no worries. Okay, to everybody's, I just read the recommendation. Are you all in agreement, please? Thank you very much, and thank you very much for coming today and bringing your strategy. Thank you. Best of luck.
When you do the recommendation, so you can say that the scrutiny committee agreed with the recommendations.
2 o'clock. I'm going to have to do it.
So, I think. So forget that.
Agreed with the recommendations.
Item 11. Just going to sit on your seats as much as you
Exactly.
can. Item 11 is the lead member's annual report, the adult social care and housing. And I'm going to invite Councillor Sarah Wakefield, lead member. Over to you, Sarah.
Well, we all have to do an annual report.
which used to go to full council, but they're now coming to scrutiny committees. I hope people have found it interesting. It does contain some interesting statistics about the amount of work done in the team. We have included reference to the TQC report because it was being finalised just when the report came in, so I thought it was appropriate to refer to it. I haven't anything particularly to say about it, except that I think it does summarise the variety and depth of work that we do in the team. So I hope people have found it interesting, and I'm happy to answer any questions that I can with my team here.
Councillor Power.
Yeah, thank you. Thank you, Sarah, for your report. It was actually quite good to read and to see, but obviously with the news of the CQC report, it was actually good to see in the report the actual other work that has been going on. So yeah, I just wanted to highlight that. Thank you.
Do I have any other? Councillor Trimmer.
It's not a question, unfortunately, but just I always enjoy reading through these because of the statistics. Absolutely full, packed full of information. I'll print it off and I will keep it for reference. So thank you for your efforts.
Yes, I would like to say I think the council budget, it's amazing to see how many contracts, referrals, but the detail in this, I think, was very. You do need to keep a copy of this, I think, for everyone. Yeah. I think it's important to keep a copy if people can print, because it really is. And it's actually a shame. Unfortunate, I have got a copy, but I think it is something that report, Sarah, that's done very well. And I like the fact, Sarah, with the greatest respect, it's not reams and reams of stuff. It's actually statistics. I'm a great statistic lover. I like being able to look at something straight away and be able to see it. And I feel that, could I just ask one question? On 14 local government social care ombudsman complaints received, is that a good, were upheld? Statistically, is that, sorry, 12 were upheld, I apologise, sorry. Is that a good statistic? Is that good?
It's reduced down.
Is it?
What has been.
That's what I meant. In comparison, is that good? Yeah.
Actually, when the report was being put together, I did ask for a little bit more detail on the figures. I think if you see them out of context, for example, it didn't originally have the numbers of pending care act assessments and pending care assessments. I wanted that in because you need to see where it really is. And certainly we do we do look at other authorities and see how they're doing. So benchmark, that's the word. We do benchmark what we're doing, but perhaps we could put a little bit more about that if that would be useful for people to see. Because obviously we're saying what we've done and you don't know what they're doing next door in the next door county. I get that. So we could certainly look at that. I would like to just pay tribute to my colleagues because I, of course, did not write this report. I had an input in the introduction and looked at it and made some comments on it. But it is the team that writes it, and particularly under Vicky Chase, and they've done a very good job. So thank you.
Yes, they have. And we could send our appreciation to that, please, because this is a very detailed. I mean, I know what you're saying. We could do more, but I think comparisons, I think, would be the answer. For us to have comparative figures would it actually brings it real, it makes it real. So I think that would be really good in the future. Councillor Bruce.
Thank you. This might be a silly question, but I'm not really sure I've understood correctly. How is 1% of the council budget? What do we mean when we say housing? Are we talking about the staff to run the housing service, or what? And then the 38% for ASC. What is ASC here? What? Adult social care. When I first started doing this role, I said to Mel Locke, "Oh, well, you've got such a big budget, you've got so many staff, haven't you?" And she said, "No, I've got 400 staff, actually, which is quite a lot. But no, the cost, 90% of what we do in adult social care goes on Care Act payments and care home fees. It's the money we spend out, and also on the big contract we've got with some of our support providers that look after large areas of work for us. For example, called Discovery, they have a contract with us for about 60 million a year. I mean, it's huge because they're looking after mental health
patients, so-called learning disabled patients. So it's the size of what you have to do, because although we've only got, I think it gives here the figures of people we're looking after, those care home fees, Graham said we're very mean with them, but they are really expensive. Privately, this is, privately you might pay £1,500+ a week, we pay about 9. And because we've kept them down, and in fact we're much lower than Devon. But you just have to be aware that that's where the money goes in adult social care. It's not on staff. I think Kirsty will answer about how.
Yeah, so it's key to know it's not our housing stock. So this is our housing options, homeless service, rough sleepers, our displaced people service, our affordable housing team as well. So it's not a housing stock. HRA sits completely outside of this. Our budget's about £11 million a year, which compared to adults is tiny, but it's not insignificant, and obviously the impact that it makes. So that does include commissioning some of our services that we have around some supported housing, temporary accommodation, etc.
Thank you very much. I know that Helen's been doing a tremendous amount of work on libraries, putting documents in libraries. And this is, the last two items would be a really good one to put in the library. Which I've never been able to have a library personally myself, but Helen's been doing a lot of work with the Task and Finish group. So not that I want you to do any more, Helen, you're doing far too much. But I think, again, to reflect on looking at those documents, that would be really good to have them in there. So thank you very much. Thank you very much to the team. Thank you for the work, and we do appreciate it very much. Okay, now then, this is item 12. This is the committee work. So I invite Jack.
Yes, thank you, Chair. Yeah, I really have nothing to add apart from that a couple of items have been suggested from this meeting to be added for the work plan. One is further updates from the ICB on the provision of GP services in the area, which you agreed, to be on the agenda for 8th of October. I understand.
Yes.
And we will also have a further update from the colleagues on the what is it? Somerset Health Determinants Research Collaboration as well for January. If we do struggle to put that item on January agenda, I'm aware that maybe something around budget issues within January. So we will also consider February. You have meeting beginning of February as well. So just in case this doesn't fit in January. You may also be having, subject to advice from officers, pharmaceutical needs assessment, which may come to this committee for observation, because I understand that it had been considered by the Health and Wellbeing Board Somerset Board a couple of days ago, but further updates may be needed, so it may come to this for the scrutiny to consider that as well. Apart from that, I have nothing else to say, Madam Chairman.
Thank you. What I've asked for is that we've asked for the Somerset Ambulance Service to definitely be our next September meeting. We've had that put back several times, and I want it there now. And I've said to them that we want the response times. We want that. So we've asked for that now. So I think that that's why we put the oval as well in into the October. But if you want the oval one moved into the September, we can do that. So it's really up to members what you want, really. We need to give people enough time. It's very, very topical when you want something, but if we don't have enough time for people to get the reports in time, then it's going to be useless.
Sorry, I might have missed why you might consider moving, I presume you mean the Yeovil District Hospital maternity update to September. I guess if we leave it in October, we've got more time to assess, or for
We
them,
have.
to assess how things are going, because they've only just reopened and it's a phased reopening. So I'm wondering if it might be best keeping it where it is.
I think you might be right, but there's a lot of media coverage about Yeovil, and there was just some couple of members had said to me previously, I'm a bit concerned about that. If you're happy to leave it in October, I am, but it was on the media quite strong, and I just felt it would be nice, and I have asked now, but when the statement goes out, the press release, that we need to say on the bottom that this will be looked at scrutiny, so that we've got a bit of a backup for this committee, because many things come up topically, but it is very important for us to have that on there, that this will be addressed at the scrutiny committee.
May I just come back?
Yeah, sure.
Sorry, Tom, so it's only a quick one, but I think it came back in a mention, a localised mention on the back of a national report into maternity. Is that what you're going to say? Sorry, Tom. Yeah, go on.
I was just saying, I completely agree with what you said, Lucy, but waiting for October, because as you said, it's a phased one. There's no point in just bringing them in earlier when we haven't got all the data and all the facts and figures. When we can, if we wait in October, we can really start to scrutinise and get some proper information. Because if it's just like a phased return, they're not going to be,
As long as you're
fully
happy.
organised. Yeah.
That's fine. That's where it is in October. I just wanted to make sure that this is your committee, and it's important that you have on here what you want. Do you know what I mean? So is everybody happy? It's good? Lovely job. Right then, well, I can truthfully now say the next meeting is on the 4th, which is a Friday. Sorry. Oh, Hilary. Hilary, Hilary, I apologise. I'd now like to invite Councillor Hilary Bruce, Chair of the Task and Finish Group, to update the committee on the progress of the group and the date of the presentation of its report to the committee. Over to you, Councillor, Chairman of the Task and Finish.
Thank you, Jill. I'll keep it brief. It was just to say, to update the members that we had to add an additional meeting into the Task and Finish Group schedule, and that's pushed the date back for when we're going to be able to come back to the committee with the results and findings. We were hoping maybe to do it in September, but the timings of the processes just doesn't allow it. So we'll be back in October with results and findings from the Task and Finish Group. So if anyone has any questions, welcome to email me directly, and I'll deal with it maybe after the meeting. Thank you.
Right, does anybody have anything? We must have it by October, no later, okay? Because obviously this has been a lot of work for Helen. I want to thank Helen particularly, and Jack, but Helen's put a lot of work into this. And Kirsty. Sorry, Kirsty.
Sorry, Kirsty. Thank you.
No, but I want to thank you all, and thank you, Sarah, for being here today. Hope don't rush in that traffic. And but I just want to say that it is appreciated. But also, what I was trying to say was a lot of admin that you have been had to do, Helen, for this Task and Finish, and I just wanted to thank you very much for that officially, because I think you have really gone overboard to some extent, and I appreciate it. So, but I think it's a hard chairman. I blame the chairman. Okay, so thank you. That's the meeting closed. Thank you very much.